Welcome everyone. Let's just see where we're at. So it's 10 o'clock. Welcome to the Cornwall and Isles of Scilly Integrated Care Board meeting. We've got a packed agenda as usual today, so we'll try and push on through at pace if that's all right with you all. So a few welcomes if I may. So in the room we have Kate Maynard. Welcome, Kate. You are our interim Chief Operating Officer, and you've been with us how long?
I think this might be day 8 or something like that.
Well, the fact you're back in week 2 is fantastic. That's great. So welcome. Feel free to ask what you need to as you go through the meeting, please.
Thank you very much.
We also on the screen, I'd like to introduce to colleagues Molly Marco. Molly is here today to observe the board as part of her orientation process. She'll shortly be joining us, coming to do some advisory work with us, particularly on things like joint committees and that, but particularly to help advise Kate and myself as we go through the next period of governance issues. So welcome, and there she is on the screen. Welcome, Molly.
Thank you, Chair.
We have a number of apologies. I won't go through the list of apologies, but Caroline, if you'd be kind enough to take a note as to who's actually here, by definition, that would be really helpful. I don't think I've missed anybody on that basis then. So moving on to item 2, declarations of interest. Are there any other declarations of interest anyone wants to raise regarding the papers? No. We have 3 questions from the public. Let's go through them in the order. So, Susan, could you deal with the first one on 111, please? Well, shall we go to Chris? Have you got the intermediate care one?
I can do.
If you do the intermediate care one, Susan, we'll come back to you on that one.
Would you like me to read the question out first?
Yes, please.
So question is, demand and capacity of the intermediate care strategy and delivery plan states that there is a shortfall in the amount of pathway 2 capacity, bedded rehab. What are the actual numbers of beds currently available and required to meet planning targets? Given the demographic structure of Cornwall and the particular health needs of that population, what research has the ICB completed to assess the required pathway 2 and pathway 3 capacity in Cornwall by comparison with the national planning guidance? So the answer that we have put together is the ICB has undertaken extensive analysis of historic hospital discharge data to develop its demand and capacity plan, and has used this data to compare itself to national NHS hospital discharge guidance, which is referenced in the strategy. The demand and capacity plan has subsequently been reviewed by a team led by Professor John Bolton, which was assembled for Cornwall as part of the National Discharge Task Force. The team confirmed the assumptions and analysis underpinning the demand and capacity plan. The current shortfall in pathway 2 capacity identified within the demand and capacity plan is primarily caused by challenges in discharging residents from community rehabilitation beds, primarily in community hospitals, with package of care at home, pathway 1, and in placing people in long-term residential care, pathway 3. When these challenges have been addressed and the average length of stay in a community hospital bed is shorter, then it's likely that the number of bedded rehabilitation beds available in Cornwall will be sufficient to meet the demand required, recognising the specific population needs of Cornwall and the Isles of Scilly and the national planning guidance associated with this.
Okay.
I've just got one more paragraph, sorry.
Yes.
In particular, by commissioning the additional 172 Pathway 1 discharge support packages each month in 23-24, it's anticipated that the number of people waiting in hospitals to be discharged will reduce substantially, and that the system-wide target of no more than 88 general and acute beds in RCHT are occupied by people with no criteria to reside will be met.
Okay. Thank you very much. So let's move on to Steve, the third question relating to urgent treatment centre at West Cornwall Hospital, please.
This question is, will the board publish in full the information and judgments on which it's based its decision to support the continued overnight closure of the urgent treatment centre at West Cornwall Hospital? The answer given is RCHT is commissioned to provide urgent treatment minor injury services through the Urgent Treatment Centre at West Cornwall Hospital for 24 hours per day, 7 days a week. For 10 months, this has not been possible due to staffing issues, including challenges to the junior doctor cover. And at present, the UTC is open between 0800 and 21:30 hours daily when a full urgent care minor injury service is provided. The UTC remains open at the times during which the majority of demand presents. The ICB notes staffing issues such as 2 emergency nurse practitioner vacancies and a further 4 emergency nurse practitioners on long-term sick leave have been experienced despite the trust advertising for staff, but without success. Whilst the ICB has not given explicit support to the reduced opening hours of the UTC, it does recognise the staffing challenges experienced by RCHT and is confident that the Trust is doing everything within its powers to resolve these staffing difficulties and return the service to its contracted 24/7 operating hours.
Okay, thank you very much. Now, Susan, I appreciate the answer to your question. It's a very long answer. How would you want to deal with that?
Could you, is there another question to be asked? Could I come back to you, John, on this, please?
Who has it, the answer?
Part of the answer here from, but apparently there's an email that I haven't received.
Caroline, could you send that straight and I will come back to that. Apologies. Okay. I'll come back to that after the minutes. Yep. Okay, so let's move on to approval of the minutes and matters arising. So, as always, I'm not going to page turn or whatever, but on the minutes, are you happy for me to record them as accurate, or any changes or factual changes you want me to make? Everybody happy? Lovely. Okay, so we'll take those. Caroline, on the actions and matters arising, is there anything that you feel we ought to pick up and deal with now?
Caroline.
Caroline, is there anything that you feel no? Oh, and Caroline? No? Okay, so the only, so I'm just opening it up now. Ooh. Wi-Fi is very slow. On the actions, I found the item on, let's get to it here, old-fashioned paper bit. Nope, we're not having a very good day. Where are the actions on here? What action? Yeah, where is that on? Yeah, if you give it to me. In the papers. That's all right. Got it here. Okay. So the item I just wanted to touch on was Tommy's story. I was trying to remember what the Tommy story was actually. There's an action line. So can you just pick that up and take that back and make sure we've got an action for that, please? Thank you very much. Yeah.
Ask that we do a review of this action grid and that we bring it back to the next board meeting so that we can go through it to make sure, because some of these actions are from March 23, so we do need to go through it and just either close or clear and understand what they are. Thank you.
Again, the paper's just come through. It's rather late. There you go. Are you good to go? Right, Susan, please come back to your question on 111, please.
Apologies, Chair. It's just taking a little time for my laptop to connect. So the list of questions that I've got is, how is 111 service performing in terms of waiting times for calls to be answered, waiting times for clinicians to call back, repeat calls because of delay in clinician callback, patients' conditioning worsening, numbers of patients that are referred by ED, and numbers of calls abandoned. So shall I go through them at very high level and can fill in any further detail if necessary? And
then if we can post the full answer, please,
absolutely,
on the website, that would be lovely.
Okay, so firstly, the metrics for the service are overseen by the Cornwall 111 IX board, which is a joint between us in the Integrated Care Board, RCHT and Kerno Community Interest Company. It's co-chaired by the ICB director and supported by Commissioner Leeds. Performance metrics are subsequently included within the performance report that goes to the ICB Finance, Performance and Commissioning Committee, and the most of which we can attach and share if required. Happy to do that. It's the intention that the Finance Performance Committee will also be shared with the Primary Care Commissioning Committee in order that this now PCC, the Primary Care Commissioning Committee, can debate and agree the scope of the metrics that the committee needs to oversee on behalf of the ICB. The most recent performance reports with these metrics will come to the June Primary Care Commissioning Committee. So again, we can publish it for then.
We'll put the full answer on the
Yeah.
website. Good.
So waiting times calls to be answered, current data, current on average is 157 seconds. Waiting times for a clinician to call back out of 2,260 calls to 111 requiring a call back in 20 minutes, 57%, which was 1,283, were called back within the time frame, of which 739 online contacts where a callback was requested by the user. 406 calls, which is 55%, were all made within 20 minutes, and all patients who requested a callback received a call. Repeat calls because of delay in clinical callback. This data is not routinely collected. It's in the national data set, so I'm sure we can access that for a fuller answer. Numbers of patients then referred to ED by ambulance or own transport. Of over the 3,000 calls in May, which were initially categorised as attend ED, only 211 people, that's 7%, were referred to ED. And this was following the caller speaking to a clinician to confirm ED attendance was only clinically necessary. And lastly, the number of calls abandoned, 11.5% out of, which is 2,536 calls out of 22,000 calls. Each call is counted. So someone calls, hangs up, then calls again. That would be counted as 2 calls.
Okay.
Thank you. Apologies for the delay.
No,
in getting you the
don't
answer.
worry. And thank you. So moving back to the agenda. So just for good form, in case I skipped past it. So we've approved the minutes and we've agreed to refresh next time the full action plan. Yeah? Lovely. Thank you very much. So back to normal form, subject to Wi-Fi. Okay, so health and care vignettes. So as always, Lucy, fab range of topics here. I'll let everybody else go first. Any of you want to pick up on and particularly tease out that you found particularly interesting? No? So, Steve?
Thank you. I'd echo your comments to Lucy. Incredible stories. The two I particularly wanted to comment on, the first one was the dementia experience, and the things that came across really clearly to me from that were the importance of joining up care and the challenges that we still have in the system about joining up the various parts of health and care to support patients with dementia, and also the importance of access to respite and the gaps and the challenges that we have in access to respite. So I thought there were very clear messages from that. The second story was Penny's story, which was exceptionally challenging and a traumatic experience. What stood out there for me was the importance of the voice of the family in escalation of care and the potential for that care to be informed and shaped further through the family, and also, I guess in a similar vein, the opportunity or the gaps in the voice of family in lessons learned and in investigations. So it was an incredibly challenging story to hear with some clear points that came out.
Thank you. Ali?
Yeah, thanks, Chair. Like Steve, I thought there was such a broad range of vignettes this month, and really powerful stories. Again, on Monica's story, really around the dementia, I was left wondering if she was accessing support and getting support. It wasn't really clear in the vignette whether she'd asked for a carer's assessment or any respite services, just saying that that's what she'd like, and that kind of support to head off the crisis, I think were her words, before they get to that point. So So obviously I can't, I don't know who she is other than the story today, but I wouldn't mind having her contact details so I can just follow that up with her as well, because it just left me wondering, were they getting the right support? Thanks.
Referring back to Penny's story, Penny is now a governor at CFT and is incredibly valuable to us. I reached out to her and said, could she join us as a governor? And she did, as elected one. So she's absolutely marvelous and is very helpful in shaping our
Thank you for that. Emma.
I just wanted to pick up on what Steve was saying, but with a slightly different lens. So one of the things that was a thread through a number of the stories, but also in other conversations I'm having, is that wider family support. So Steve picked up on the issue of involvement in the kind of care planning and post any crisis. But I think there is something for us all in all of the services that we are designing and contracting to ensure that an element of that provides support for carers and families, across all of our different services, because I hear that when you're talking about parents of children with autism and neurodiversity, parents of children going through the transgender experience, carers of dementia, it's a recurring theme, and I don't know that we necessarily give enough capacity and resource to that in our contracting and commissioning.
So it's a broader response that links things together. So we are recurrently hearing that people don't feel personally involved in their care and that families feel excluded from care. And I know we're doing some work following the Hearing Voices video, but it's much broader than that. So I think there is something for us to consider about, as a health and care sector in Cornwall, how we're supporting our people to be able to respond appropriately, and also what advocacy services we've got, because being able to access resources isn't always within the resources of the individual. I agree entirely.
Yes. Do you want to respond to that point, Margaret?
It's on its related point,
Yes,
which
please.
is the complicated. Can't disagree with what anybody says, but there is the issue of consent and varying consent. So if people have capacity, they have to give their consent for information to be shared. And I think that's one of the issues that we need to think about very carefully, because it may not be in their best interest, but if
That's a
they have
different point.
capacity, and so I think it would be worth us having a conversation about how we, because it isn't just mental health services, it's lots of
Did
services.
we capture that?
So I think that's a how we do it thing. So
That's what I'm saying,
the
is
fact
we
that
need to talk about
and I don't think we should discuss it here.
No.
I think it's something that we should be asking our providers, all providers, to be able to tell us how we would be able to work with people optimally.
Okay, so just before I go to Tan, Ali, was yours on
Yeah,
this point?
yeah. I think mine was a slightly different point, because I completely take your point, Mari. It was more about when we're configuring services, that we configure in a support element for the carer or the family, so that they have their own support to enable them to better support the person who's going through
I can
that.
see
And
lots
I
of
think
people.
that's a...
Margaret's nodding vigorously. Thank you for that.
Sorry.
Those who can't see that. Tan.
Yeah, I'd like to laud the breadth of the stories that we're getting here. And if we actually think back about over the last few meetings, actually, the variety of different stories we had. So thank you to the team for really reaching out. And for the braveness for the people that are actually bringing these things to life for us. I find these really give us a real deep dive into the services that we have. I want to make sure that we're capturing the learning that we're making from all of these stories, because when people tell their braveness, find their braveness to tell their story, they're not doing it just to give us some information. They're doing it because they want to achieve change. And so there's one other thing that I've just mentioned to Lucy, is at the moment what we're doing is looking at how people have access to service, and I think that's fine, but actually what would be really good is to look at some people's journeys, their life journeys, their families' journeys around health, and particularly where they've got complex and multiple needs that are cycling round and round in the system, where they've experienced lots of trauma, and that's impacting on a whole variety of different services rather than just one service, and how we then view it through that lens.
Okay, thank you. So Ali, before I hand over to you, if you could make your point, but also just share with us, if you're going to make a different point, but share with us your thoughts on the support match home service. It seems amazing, but do make your point first, please.
Thank you. Yeah. Okay. So the point I was going to make was that carers have a right to support services in their own right. And I think that's really important that we recognise that as a system. The Safeguarding Adults Board had a conference this week, their annual conference, and it had a focus on carers. And obviously this week is Carers Week, which is really good that we're having this conversation about carers. The SAB's theme for carers this week was because there's been a lot of learning through some of the Safeguarding Adults reviews that have happened across Cornwall from over the last few years. So there's been a bit of a theme. So I think it's really important that we learn the lessons from those SARs, but also that we work with the people that are in caring roles now across Cornwall. You know, I think there is a significant number of people who are providing that kind of care and support to their loved ones and maybe not known to services as well. So the more we can do to raise awareness of the role of caring, I think that would be really good. I think the latest census, and I'll be corrected by Rachel Wigglesworth if I get this wrong, but it showed about 10% of our residents are caring for someone informally unpaid support. I think that's about 57,000 people across Cornwall. So we absolutely need to support them to carry on doing that role. So that was the point I wanted to make. The vignette, that was Mo's story, wasn't it, on the home share? I have very mixed views, if I'm being honest, about home share. I think it needs a lot of governance around it. It's really good to hear Mo's story and that it was working for them. But as a statutory director of adult social care, I think it's really important that we get that right for people. And I think there are some implications of it. But it is absolutely fantastic if we can match the right people and we've got the right governance in place. And it was really, really clear, wasn't it, that that this was working for Mo, and her son was very happy and had assurance and confidence that Mum was okay while he was out working, which was a move away from, you know, several, I think he said 50 calls a day sometimes. So so I think that's really helpful. So I think it's for the right person, John. I think it's great, and we need the right checks and balances in place for it, which I'm sure we do have. It doesn't sit within adult social care, but I am confident that we've got those checks and balances in place. But I do think it's something that we need to make sure we're only using it in the right instance. Thanks.
Okay. Debbie.
Yeah, so absolutely welcome the breadth of stories, but also the proactive work that Lucy and team are undertaking in building the future pipeline of stories as well. Yep. So I'd like to really thank you for that. And whilst there is really important learning, and I absolutely concur with Tarn about the bravery of people coming forward and telling their stories and also wanting us to make change on the back of it, we've also got positive stories where we have picked up on learning and have started to make changes. And I know that Lucy's really happy to help us with telling some of those positive stories. And that's not to decry that there's so much more we need to improve upon, but it's not all doom and gloom.
Right.
And I've started to see an increase in the number of people talking about an improvement in care in Cornwall, because we've had bad headlines and actually people are more increasingly saying, I was surprised, I actually had good care at this hospital, that hospital, this hub. So let's not lose sight of that. I think there is a piece, as Kate picked up, about individual practice, which we are all responsible for ensuring the learning feeds down through our organisations. But strategically, for us as partners on the ICB, we all have a duty to collaborate. And when we're thinking about and designing future services, we need to ensure that we do more on the interface between those services, and that we're really clear about how people move between those services and what the escalation protocols are. Because I think we've still either got gaps or duplication, and we have a bit of a risk of a potpourri of offers. Okay. And I think it's in our gift as an integrated care board to actually grip that now during the course of this year.
Okay.
And I think that plays to the discussion we had last board around place, and saying to people, if it's in your place, you are not allowed to, but expected to be able to work across your teams in order to make things work. And if that isn't happening, Steve offered to unblock any stuff from RCHT, you offered to unblock anything from CFT. We will do anything for commissioned services, but resources at place, your people are your people. So how do we make the most of what we've got?
And we'll chat a bit later about performance, but I too am picking up those green shoots of better news in lots of different places. So that's very encouraging. Okay, so Lucy, anything else you would like to end on this particular section?
Just really to say thank you to Monica, Stephen, Penny, Mo and Clive who feature in this month's story. And
Yep.
we are doing lots of great follow-up work with a lot of them in actually shaping what we do next. It's worth flagging that there is some emerging themes, both from the films that we're seeing, but also from our engagement activity we've started in May and it runs until September. And that is that emerging need to listen to families and how their involvement and knowledge can help our medical support that we need to deliver, but also the importance of compassion, not only in the care of our people, but also after the death of a loved one, which really came out in Penny's story. The importance of aftercare and ongoing support is really interesting because it's a theme that's emerging both from Monica and Alan's after the diagnosis of dementia, but also with on a practical level with Stephen after his torn retina, and just, you know, how important it is that we actually stop avoidance after an issue has happened for a loved one or an individual too. So we'll bring the findings, as I say, we are coming back to the September board with our learnings from these films.
Yep. Very good. And I think that's such important that we have these sessions and then follow up on them. And then sometimes strategically, we might actually build certain things on them. And I know Chief Exec wants to talk about one of those in your update that's come from a previous vignette. Okay, shall we move on? Everybody happy to move on? Lovely, thank you. So, Chair's update. Please take it as read, but I just want to tease out a couple of bits. One is I just wanted to put on record the thanks to Cornwall Community Foundation group for the support in helping take what is a small amount of money in terms of the scale of everything, but £300,000 is still a significant amount of money that might make some difference at place level. I'm so pleased that it was used at a third sector delivery and in conjunction with our managing directors who were engaged in the decision as to what was done, how it was done locally and that. So I think this is a good example where we've taken some funding, tried to focus on place, use the third sector and the voluntary sector to great effect, focused it, and in this particular issue, focused on the mental health of young people in our area. So thank you to Tamas and to CCF on that. Other than that, I've mentioned Molly's joining us as an advisor to help us, and part of that is to help us through some of the governance changes that we may or may not go through, particularly focusing on things like joint committees as we go over the next period of time. And Mary, looking forward to your deep dive as we go through the day on care homes and that. So anything else on my report? If not, please take it as, yes, Debbie.
Could I just reiterate my declaration of interest that my husband is treasurer of CCF, and therefore I took no part in the decision making to allocate the funds, although I do welcome the allocation to the VCSE and the support for mental health.
Very good. Thank you for that point. Okay, so let's move on to Kate, your Chief Executive update, please.
Thank you, John. So I'm sure you'll have all read my update, so I'll just pick out key parts of it. So one is us being in the Tier 1 for urgent and emergency care, and the work that we're doing with Neil Maloney, who's the national lead in NHS England. It builds upon the work that's already been done, and a lot of progress has already been made, both within RCH and CFT and across our system. So we will be accessing every bit of support we can so that we can make our services better for our people, and that'll start coming through in our performance reporting, where we can see no criteria to reside is sort of reducing, ambulance performances starting to improve, and we will hopefully support RCHT in making sure that we turn those ambulances around quickly and get them back on the road. Doing a really exciting piece of work with the Isles of Scilly. So I went there a couple of weeks ago, and as a little microcosm of the issues we have across the whole of Cornwall, you can see it really clearly in the Isles of Scilly. So we've talked for a while around how we have single leadership, bring teams together, people working in place for people, and we're bringing together a small group of ex-military or current serving military personnel who are used to providing care remotely from mainstream hospitals, diagnostic units. So we've got a meeting, I think it's next week, as a kick-off to start looking at what we could do on the Isles of Scilly that maybe we could model and use elsewhere. And I'm just minded that there are other rural and remote locations in the UK. So perhaps some of this work could be real test bed work So we'll report back after we've had the first meeting. I'm conscious that there are lots of other pieces of work that are taking place. So after we've had the first meeting, I think we just pull it all together into a single improvement programme for the Isles of Scilly, and we'll bring it back with regular updates. That links in with Transforming Care for Cornwall. So we've reviewed the way Transforming Care for Cornwall has been functioning. We are resetting our transformational programmes, aligning them with our recovery programmes and with our quality improvement, so that we've got a way of, through different governance arrangements, making sure that we are addressing all the things we need to across the range of services that we are purchasing, delivering and evaluating. So we'll bring a paper back to the July board with clear governance so that we're clear how Transforming Care for Cornwall fits into delivering our operating plan. The dementia conference was amazing. I'm smiling as I say it because I burst into tears on the stage, which I'm sure many of you will have heard about. I really don't know why I did it. So my mother has been dead for 5 years, but there was something about the dramatic presentation around family stress and strain around dementia that all of a sudden made me inarticulate and unable to speak. So part of me wishes to apologise, but part of me also wishes to reflect. We are but human beings, aren't we? And we all get affected by.
Don't apologise for being real, Kate, please.
Absolutely not.
We all are affected by the things that we're trying to deal with. It's a really great conference. Alison Hibbert and the team that are taking the work forward were amazing. And next year, I'm sure we'll be building even more on the work that we've been doing to date. We had the ICB chief execs and NHS execs meeting, and we had breakout sessions around patient choice, primary care access, which we've got on the agenda for today, and also medium-term strategy around engagement. The choice agenda has never gone away, but it's going to be really clear that from 40 weeks, anybody who's been waiting 40 weeks or more will be offered the choice of providers, and we will be expected to respond to that choice and to make sure that we get people into care and treatment quickly. And we're going to come back to choice at the point of referral, where every person who needs to be referred into referral to treatment pathway will be offered 5 providers, so that they can exercise the choice. And if we go back to the Isles of Scilly, there are people on the Isles of Scilly who are exercising choice to go to the Midlands, to London, not necessarily just to receive services in Cornwall. So again, we will bring back the implications of those things to future boards. And then the Junior Doctors Industrial Action, we continue to work with our providers around how we can support Cornwall to be safe during the next period of industrial action, which will be next week. There's also some great news that isn't in my chief exec's report. So Steve and the team yesterday were doing the media announcements around the Women's and Children's Hospital at RCHT. It's very exciting, and for Cornish people who want their babies to be born in Cornwall, it's a massive development. So be great to see that going forward. And then the urgent and emergency care unit at University Hospitals Plymouth, again for our north and east population, we're starting to get better access both in Cornwall and also in Devon. And also we've put in our final business case for the elective surgical hub, which will go on to the St Austell site so that we can start increasing surgical access for north and east patients in the place that they live. I know St Austell isn't quite north and east, but it's nearly north and east. And then the last bit I just want to pick up is some ongoing discussions we've had since the last meeting around the community development workers, or the Brazilian model. I think some of that conversation was had yesterday in the Primary Care Committee. One of the things I was just reflecting on it while we were talking, if we could align our ambition around the work that Rachel and her team have done at Place with the strategic development of sustainable services with the third sector at Place, and looking at how strategic partnerships could be built upon in the places where people live, then that might be a really good way of us starting to address our core 20+5. But also putting some really sustainable infrastructure in place across our places. So again, we'll bring more of that work back to future boards.
Any questions for Kate?
Chris, do you want to comment at all on the Brazilian model?
I think I might ask, yes, Andy, because you were part of representing Place in this concept. I think
I think there was a really good discussion around once we demonstrate a model that can help with equity or addressing inequity, moreover, and it's place-based and it's community-facing. Is there an option to scale up, for example, the Brazilian model? And if so, how do we go about it? And I think what was the ICA sort of MD's opinion on this to roll it out, as it were? Andy?
Debbie's got her hand up, but I'm happy to come in. So, place is all about localism. It's all about communities. What communities' assets are, what their strengths are, but also knowing their own community and developing their response to that. But at the same time, we can't ignore the bigger picture. We can't ignore the system in that. So there's something about how can we develop projects locally, knowing what we know in our own communities that help the wider system, and the community health service worker model is likely to be part of that. But how can we embed it locally with local-based leadership to show a system benefit?
So, Chris, the other thing which just suicide on, because as Neil's not here, who chaired the ICA committee where this came up, I'll just give some observations because I attended that meeting. Is particularly delighted last night to actually get a note from Juliet, who leads now in the West, to say how supportive she was of the Brazilian model. And of course, in some ways, even though it's been internationally trialled in London and whatever else, of course, Donna led some of this at place level in the centre. So in fact, it's not just a model we've taken from somewhere else, it's being trialled and that kind of thing. So my understanding from the conversations is that it's got general place-based support because it's a place initiative, and that, Kate, you're likely to put some funding behind this to make it scalable in this current financial year. But we leave Kate to work out quite how to do that with colleagues. Is that fair?
Yeah, can I just pick up before you come in, Chris? So at the Devon board yesterday, I don't think Jane's here today, but at the Devon board yesterday, we were talking about whether there's the opportunity to do a couple of big campaigns annually that do end-to-end stuff, so prevention through to palliation. And if we had this sort of infrastructure at place in our communities who are the least likely to access preventative measures around hypertension and atrial fibrillation monitoring, for example, we know that if we could put good services in place for hypertension and atrial fibrillation, we reduce strokes in 6 months. So if we're looking at a positive benefit for populations who aren't accessing preventative treatment, then our places have got the local knowledge and the information. We just need to bring it together so that we are addressing mental health issues, and people who have poor mental health also might have hypertension. So how are we making sure, in fact the evidence tells us that they do, because they don't tend to access a broad range of preventative services. So I think that now's the time to start layering some of our things together and using, Andy, the fact that people in place know loads more about the right way of doing this, but there are some things that we know will positively improve outcomes that we need to be introducing to each other.
Just bear with me. Debbie, yours is a different point, so love it. Thank you. So Martin and then Emma.
Yeah, so a couple of points on it. I mean, first of all, really supportive of the community health worker model, stroke Brazilian model, whatever we're calling it now. And I think when we talked last time around what are we proud of thus far, I thought that was the things that would really look like it can make a difference to, the sort of prevention, the inequity and lots of different parts. So I think it's great. I suppose my but is, I was also really supportive last year of the community hub model, which fell out of the warm hub model. And if I was here a couple of years ago, I'd been really supportive of the social prescriber. My point is that we perhaps in danger if we're not careful of how do we ever look back, I suppose, at all the things we've done and say, well, this one supersedes that one now, and therefore we don't need to be doing that anymore. And I think, when I look at the paper coming up on intermediate care strategies, that's doing quite a good job at picking up loads of different pots of stuff and saying, actually, these can be coordinated now in a different way because they've been sort of piecemeal things over the years. So I guess it comes back to your tension about how do we do the sort of coordination top down, but make sure we don't lose the sort of localism. And I think that's a very good point. But I do slightly caution about how do we ever look back and say, well, if we're putting something new in, is there something else we can sort of downscale a little bit?
The national view of us is that we're really innovative, but we don't scale our innovation. Yeah. So there is something in that about how we look back and make sure we scale it.
So one of the themes, Martin, is that I'm hoping that we're going to give board support to is empowering Kate to take what's the idea that really came to large at the vignettes, everyone was excited by. It seems to work, but taking the point, innovative, but we've got to scale this. So this could be one of the first ones we do that. So I'll give in the order in which you're going to. Is it on this point?
Yeah.
Okay. So we'll go Chris, and then we'll Rachel, and then Emma.
It's just to build on Andy's point that to roll this out and it has to be place driven, because they're the people. If we believe in this concept about knowing the person and their family, so the model is great. And as we grow it, so that as we scale it, it will adapt to a more of a Cornish flavour, and so it will become a Cornish model, not a Brazilian model. Yeah. And I think that's what we have to remember. That's the exciting bit. The end result will be possibly slightly different to what it is now, but that's how we get place to buy into it.
Thank you, Rachel.
Thank you. Interesting listening to the discussion, and I've been part of the ICA committee, and public health have been involved in each of the ICAs in developing some of their inequalities based models, and I'm very interested to see how that community-based model does roll out in the mid. What we're really keen on, though, is it supports the evidence-based interventions that we know do help people. So this is the engagement and the community development approach in order to support people to improve their health, but particularly by uptake of immunisation, by, as Kate said, accessing blood pressure monitoring and support, intervening early on some of those really key evidence-based public health measures, smoking cessation. But we also need to make sure that those services and support are available. Just having the sort of interface is not necessarily going to solve and prevent a health problem. So let's not get too carried away with the sort of interface and support of the community model, some of which needs underpinning support either through public health services or through community and voluntary sector resources in other ways. So I really want to flag up, it's not the only part of the solution, and let's ensure that the public health measures are also part of that solution if that's what we're committed to tackling.
Emma?
My point probably builds on Rachel's and Andy. So I think this is a really great opportunity for us, isn't it? This is our first opportunity to do something that's potentially funded centrally, but coordinated and embedded at place. So we've got to take the time to really understand how we marry those two opportunities. I think we have to build on the assets that we've got in place, particularly if you're looking at, delivering this through the voluntary and community sector. And those assets are very different, all incredibly good, but we'll deliver a model in a different way. And I think Rachel's point is really important. If we have funding for this, we shouldn't be pouring it all into more roles. We should be looking at what do we need in place? What are the additional support services and access to other services that support us to be able to shift the levers for the system? Because, being able to deliver those things that Rachel was talking about around immunisations and some of the health benefits require us to be able to support people with a whole range of other things, including housing, employment, getting food on the table for their children, school uniforms, and a whole range of other things. So I think we shouldn't, a bit like you were saying, Chris, we don't want to hone in on those worker roles. We want to talk about a holistic approach to long-term prevention and working within our most deprived communities. And I think the place approach really gives us the opportunity to do that.
So we'll just wrap this up and then we'll come to Debbie's point. So I think what I'm hearing is support in principle for the development of let's not call it the Brazilian, maybe even San Paulo or San Redruth model that's coming, but we're giving general support, and you'll take that away and scale this up.
So I think I know this is going to sound very, very non-localistic. I don't even know whether that's a word, but we need a business case, don't we, that just tells us what it is we're thinking of doing, and how it's discharged is, I don't think is an issue for this board. How it's discharged is an issue for place, but we know there are certain things, and Rachel's talk through them, that will make a difference to people's lives now and in the future. So they're the outcomes I would like us to develop for this work. And I know there's a tension I'll address this to Andy, but there's a tension because it might be different outcomes than place are currently pursuing, because we might be pursuing better outcomes for mental health, which has to have smoking and high blood pressure and exercise and diet in it, because we know people who've got long-term mental illness are much more likely to die early from cancer and from conditions that can be avoided.
Okay, thank you. So could I suggest that we have an update maybe in September? on this? If you could, Caroline, put that in the action plan. Thank you. Thank you for waiting, Debbie. Next point.
Yes, so completely different topic, but I want to pick up from Kate's helpful report, which is around choice, and just a request that we specifically look at how choice is applied within the overall portfolio of mental health learning disabilities. We are seeing an increase in, it's a small increase, but it does have an impact of people who are waiting particularly for AHD assessments. And these assessments are being undertaken by independent sector companies. And I think colleagues will be aware of the recent Panorama programme. And so we are seeing some people coming to Cornwall with prior assessments that actually our clinicians would be professionally challenged to prescribe on the back of. So the implementation of choice is quite complex, and it only applies to a small percentage of the work within the mental health learning disabilities, but it should not be overlooked, please.
That was raised at the Devon board yesterday, and one of the things that one of the non-executive members said was, why are we queuing people up for assessment? If people have got issues, why aren't we just supporting with sorting the issues out and commencing treatment? So I think there is just something between a Devon and Cornwall discussion around what we would move into in that treatment space. So I don't know whether that's something we can take offline, because we're getting bigger and bigger numbers waiting. Doesn't seem right.
Okay, let's take that offline, please. Okay, thank you so much for your update, Kate. So we start to move into the strategic phase of the board meeting now. So if I can bring us on to item 8, which is the SEND strategy, introduced by Ali and Susan.
Chair, and I'd like to introduce Liz Cahill and Rachel Denham.
Come and join us if it's easier for you at the table.
The recent SEND inspection that we had back in February. And I think it's only right that they take us through the slides and the work that was done. I think the paper outlines where we've got some excellent practice jointly between ourselves and local authority, and where we've got some improvements to be made, I think is important to point out. So if I could hand over to my colleagues.
I could ask you to introduce yourselves, but the way we work is we have the paper, we've read it, you've got a 20-minute window here, so if you could do maybe a short introduction into it, but we have read the paper, and then let's have a discussion, and there are some recommendations at the end. So please introduce yourselves and take us through it.
Thanks. So my name is Rachel Delorme. I'm Head of Inclusion and SEND at Cornwall Council.
Hi, I'm Liz Cahill. I'm the Associate Director of Commissioning for Children, Maternity, put that one in, Maternity, Children and Young People. Yeah, so I was just going to do a brief overview. As you said, you've read the papers, but just a bit of a thanks to everybody involved in this inspection as well, from all of the organisations that were involved. So that's CFT and RCHD and the council and schools and everyone. I think it's important to acknowledge how much work went in to really preparing and to presenting some of the work that we have been doing and showcasing some of the work that we're doing. This inspection was slightly different in that there was a lot more dip sampling of cases, so it's very much focused on what were the outcomes for children and young people, and how well we're working together as a system. It's really important to acknowledge that it's a system inspection. It's not an inspection about individual organisations. So the improvement plan is about the system and how well we work together. There were some really strengths and positives. I just really want to highlight that as well. I'm really pleased that a lot of the work that we've done around access to mental health support and therapies was really reflected in the feedback from the inspection. We had some really good feedback around how we worked with families on particular projects when we were working on particular projects for improvement. But there are significant challenges, I think, going forward, really around some of our key issues. So our inspection judgment was very much about the inconsistency, and that's the important thing. So it wasn't saying that we were really, there was a significant concern. It was inconsistency. The other thing to highlight is that because of the inspection results, NHSE and the Department of Education now come 6 monthly for a monitoring visit for this to inspect our improvement journey, and so they will be holding us to account for making sure that we're delivering on the plans that we've got. This paper at the moment is a transformation plan. It's not a strategy. The strategy will be developed and co-produced for December because we've got an existing strategy. So this is about adding to the existing strategy on the results of the inspection. So I'm going to hand over to yourself to go through the improvement.
Thanks very much. Yeah, so it really was drawn out actually of the inspection. The co-production was really a strength in our system, and that is one of the reasons why we will be taking time to co-produce our new strategy update. So what you've got today is very much a working document. It's what's going on, and that's what's been presented to DFE and NHSE as well to reflect on. Other strengths that were identified was the work we do with post-16 children and how we support them in their preparation for adulthood, and we're further strengthening that work as well as we move into a different model of supported internships with DFN Project Search. We've got a pilot with NHSE as well at Bodmin Hospital starting in September. And also our early years work, so really looking at that preventative work and how can we support our young people and children in school and put that expertise into those settings that possibly then avoid escalation to an education and healthcare plan. So we're meeting needs at that earliest possible opportunity. So looking at the recommendations of the report for areas of improvement, and I would say that when these were born out of the report, I was really had some comfort because they really echoed what we'd found in our own self-evaluation plan. So last year we did lots of engagement and workshops to really understand from the system what is it that needs to improve. So that was great comfort to see that that was mirrored in the inspection. There were no surprises as such. So you can see in the papers that have been provided that there were 5 recommendations. So they focus around improved communication. That's not just how we communicate with families, children, young people, but also as professionals, how we communicate between each other. So that's about improving systems, improving data sharing, common language, shared vision, etc. Also, health services, reducing wait times for health services, and improving the quality of our education healthcare plans. So we've done quite a lot of work already on we've done a pilot to change the format of the education healthcare plan and the review paperwork to make it more intuitive, easier to navigate. So that pilot has recently come to a very successful outcome, so we'll be looking to roll that out further, but also how we might use digital tools to make access to this system easier for parents and families. So if they could log on to a portal, and that also could include professionals, and also the content, what does it mean, what does it say, what's this document going to do, and do peer review with other local authorities. So that's a really key point. Secondly, and most importantly, is what is the experience of the young person? So we're doing all of these things, but actually, what does it mean to the young person or the child at the heart of this journey, and how are these changes impacting on them? We've got a youth council now with a SEND subgroup board, and they're feeding back in. They're getting involved with a lot of this work that we're doing as well, so we can understand that, but also looking at their attainment and achievement as well, and how we can improve that. And secondly, data and how we use data. How do we become more data driven? What does our single source of truth look like? Are we all using the same information in an appropriate way? So they were the outcomes of the inspection, and then there are 2 others that we feel are quite essential to this as well. So one is a transport one, so that is about not just the financial but the social cost to a young person of being transported long distances to appropriate education. And a lot of that is to do with the geography of our duchy. So that's a longer solution that we need to find. It's about making sure that children are being educated within their communities. So that involves culture change, it involves capital investment as well, and completely different approach. And also co-commissioning and how we work together to co-produce and co-commission solutions. Do you want to add anything, Liz?
No, I think we'll open for questions.
Fantastic. Thank you very much. So, Tan, you want to go first?
Yeah, really welcome the report. Really welcome the progress that's been made in this area, and particularly to laud the work you've done around co-design and co-production. A couple of questions, if I may, around what work is they're being done to identify some of the root causes around SEND, particularly looking at poverty, particularly looking at place-based approaches in Core 20. And also for those families with repeating cycles, how they go around. Particularly struck by the education attainment gap that's emerging through COVID, and how we can actually make sure that we invest to address the issues at root cause.
Yeah,
and around transition as well. Yeah. So
Yeah.
what happens around when these young people get to being 17, 18, 19? How do we make sure that they have good transitions into adulthood?
It's really.
Yeah, so we're both got a bit of an answer, I think, to that one. So for me, the preparation for adulthood and transitions, that starts at the earliest possible opportunity. So, maybe even when you're in primary school, having that conversation with parents, which might be quite difficult because they might not be able to imagine that far in the future for some of their children with profound complex needs. But imagine, what do we want the future to look like, and working back to that. And that's a big cultural shift as well. So it's the idea of support until you're 25. Actually, if we can graduate from your plan, or if you can be successful with the support you've got to move into a positive outcome before then let's go for that, and let's use 25 as a limit rather than a target. We've got working groups already set up for these outcomes, and they're multi-agency, and they also include the voice of young people, children and families as well. So that's a little bit of what we're doing. Oh, there's so much to say about it. Go on, you go next.
I was just going to, in particular reference to the neurodiversity strategy and the plan around neurodiversity and the issues around Core 20+4, we are looking to do a bit of an analysis really on our child developmental difficulties and where we already know, but it's just getting the data to back up the discussion that we're having. And so we've got a group with public health and our leads from across CFT and RCHT that are actually looking at all of our demand flows and trying to think about what could we do differently for those families. We're already putting in some additional help. So the thing about I heard Kate discuss just before we came to talk around people on waiting lists. We want to help the people rather than just put them on waiting lists. So we've started to roll out additional support in communities for families to access, like support over things like sleep and nutrition. Our latest one is on sensory processing, which we're hoping to roll out in September. So actually get the help into those communities to really help the parents manage the need. And I think, yes, and our targets are absolutely
Lovely.
looking at where the most of the need is.
Thank you. So we're going to go to Steve next.
Yeah, thank you. Really welcome the report. Thank you very much. Just two questions. I might give them both together. The first one is, I think slide 40 identifies some resources required. It talks about program management support, innovation in comms, and investment in digital infrastructure. So my question is there a specific request for the ICB board, or is that being managed through the SEND board? And then the second question was around governance, where the paper talks about on slide 5 referencing ICB governance in that slide, and it's just a question about how you think that would best be reflected, so we're not duplicating the role of the ICP or the SEND board. Thank you.
I'll take the first question if you want to take the second. Yeah. So we've already got some project management support in place, actually provided through council. So that's really useful. And yesterday I interviewed for the innovation and comms team lead. That's a completely new team that we're setting up to really support families to navigate this, what can be a confusing landscape. So that's a completely new team, and I'm really hoping to recruit from the parent carer community as well, because they've got lived experience, and that's what I really want to tap into. So they've got that empathy, that understanding, and that we move away from this concept of having to battle to get what I need, but actually into a space where we're working together to achieve the right outcome. So those things are in hand. Digital infrastructure I'm looking at. We've got a programme with DFE called Delivering Better Value. I'm hoping that might be able to provide some finance to support that, but it's not technically for capital spend, so we've got some working out to do, but I'm confident that we've got that in hand.
Thank you. And on the governance question?
Governance question for Liz.
Yeah, so governance is a weird and wonderful thing in partnership, isn't it? But the SEND board obviously is a statutory body, but we take reports from the SEND board into the Quality and Pathways of Care Committee, and so obviously there's a commitment to ongoingly update and keep our ICB updated through that process.
Before we involve Emma and Ali, would you like to respond to that, please?
So I think if ever there was an ICP piece of work, this is it. So and we've got our 10-year strategy about a good start in life. So quite a lot of what you're describing for some of our more vulnerable young people and their families is a good start in life. So the outcomes, you know, the 1 to 5 things that we need to do. One's about access, one's around engagement, one's around assurance, and 2 around outcomes. So we're just about to start looking at our outcomes framework for starting well. And wouldn't it be great if 2 of the outcomes for starting well related to children with special education needs? So I think we could pick that up as part of our ICP agenda.
Thank you. So we're going to go Emma, Ali, and then we're going to round up, if that's okay. So Emma.
Both really welcome the report and the plan for the future, and it's lovely to see you both doing that in partnership, which is really what we see going forward. I'm sure you know this, but there's a huge wealth of expertise and professionalism and skill and experience in the voluntary and community sector around this particular issue, and we've got a structure known as our thematic alliance, one of which is disability focused, the other is children, young people and families, and we'd really welcome the opportunity to support you in delivering the recommendations, and not just in terms of engagement and service design and thinking about what could be different in the future, but also pushing that into delivery as well. So just making that offer for you.
Yeah, that's a really welcome offer. Thank you.
Ali?
Yeah, thanks, Chair. Thanks, Emma. I think that's absolutely fantastic and really welcomed. So thank you for that offer. Kate Evans-Hughes isn't able to be with us today, but she has asked me to just say on her behalf that she's really grateful to partners for their engagement, both during the inspection and since the inspection, but most importantly in taking this forward to deliver improved outcomes for our children and young people. So I just wanted to pass that on, Chair. Thank you.
Thank you very much.
Can I just pick up Emma's point?
Yes.
So you sit around the table for the ICP. So again, pulling all of that together, because we need to learn to use the new bits of organisational kit that we've got. So having us around that table, all owning this and wanting to work together for better outcomes, I think would be a really good first bit of joint work.
Okay. Shall we move to the recommendations? Yeah. So. Just before we do, I ought to say, fantastic to see the two of you, as Emma said, working in partnership and collaboration. This is really important stuff. I'd also say we don't speak enough about children and young people around here, so I think we just need to thank you for doing this, and maybe we'll think again about quite how we spend more time on this particular topic. So, see the euphoria at the end of the table. Always happy to please. All right. So let's move to the recommendations. So just picking up on Steve's question here, I think maybe you want to go away and reflect on even our own recommendations here, having just heard Kate talk about the ICP, because on slide 5 it talks about ICP exception, and it doesn't mention anywhere on here about the Integrated Care Board, and yet it's a partnership arrangement. So the recommendation has been drafted. I'll just read out and tell me whether you're happy with it. The ICB governance to be reflected in slide 5, recognising the strategies and plans and financial decisions will be managed through the ICB governance and arrangements as well. So could you have a think about quite how you reframe that one? And then on slide 27, reflects that the SEND strategy will be reviewed through the ICB Quality and Pathways Committee and receive agreement from the IC Board as well as the Cabinet at Cornwall Council needs to be considered and endorsed by the NHS. So there's something here about making sure that chart endorses both partnerships journey, but I would also say that since the paper was written, the observation about the Integrated Care Partnership, I think actually probably should be more front and centre even than the recommendations.
Take that back and
is that happy for you to take that away?
So would you do that into the more? Because when I sent you that slide deck some time ago, we've already got that one.
I couldn't catch that. Can you talk into the?
Yeah, sure. So since these papers were provided to you, we've also already started to include that in the revised
That's
papers.
fantastic. Thank you ever so much. So, everybody happy to adopt those recommendations subject to the changes we've just spoken about? Lovely. Thank you to the two of you and to the team.
Thank you.
Thank you so much. Okay, so we're moving on to item 9, which is primary care recovery access plans before the submission, which I believe has to be the end of the month. Is that right?
Correct. Yeah.
Hence the point about and delegation, everyone, in case you missed the subtlety as to why it's and delegation. So, Chris, and is Andrew here?
No,
Or is it
so
just you? Just you. Over you go.
Yeah. Recovery and access for primary care. I'll take the paper as read, but I'll pull out some key points. NHS England requires that the ICBs have agreed with primary care networks, the PCNs, a capacity and access improvement plan by the end of June. And so therefore, obviously, that works. We're right in the middle of that work. And our primary care commissioning committee, our PCCC, will if we agree, will if we delegate the work to make sure they do that reply by the end of June. So that's just to note what we're asking the members of the board are the 2 points: to note the contents of the paper and delegate to the PCC to decide the plan for submission for the end of the month. There will be, the plan will come back to the board towards the end of the year of actually what's in the detail of what's happening as well. Just as again, so some key themes. In January this year, NHS England set out some priorities and operational planning, and there was 4 key objectives. Objective 1, making it easier for people to contact the GP. That's something obviously that comes up a lot in the public about patients having difficulty accessing their GP. Objective number 2, really to actually deliver 50 million more appointments by March 2024 compared to 2019. That's quite a significant ask. Objective 3, to make sure we recruit these additional roles reimbursement scheme. So these are paramedics, physios, community pharmacists who work within primary care, which is great. And of note, Cornwall had already recruited 100% of that. So we want to build on that, that multidisciplinary team type approach. And on objective 4, recover dental activities. So there's we call it units of dental activity, UDAs. And the idea, the request is to up it from what we were commissioned, 887,000, of which only 550,000 was actually delivered, but the ask is to up it to 914,000. Again, a big ask in that objective. So following on from that, on the 9th of May, there was a delivery plan for recovering access to primary care, came out from NHS England, and that's got 2 central ambitions, which is to tackle the 8 a.m. rush. Again, the current model for not all, but a lot of GP surgeries is if you haven't phoned in the morning and booked your appointment, how many people have heard there's no more appointments, phone back tomorrow. So so I think that's a really important issue to address in the model of care. And moving on from that, for then patients to know on the day what's going to happen. So if you phone, have that answer to say, there's a doctor's appointment for you in 3 days' time. We've referred you to physio. There's a prescription to be collected. So the plan wants to empower patients. There's 4 themes: empowering patients. So we want people to have access to their medical records. And the plan is really that 90% of the population accesses the medical records. And what I mean accessing medical records, the NHS app, it's actually, can you see your prescriptions, your blood test, and actually what the doctors are writing about you. And I just thought as a straw poll, bearing in mind 90% is the target, could we put hands up if you do have access? So I have access.
Access to
your NHS app, to your primary care records. So there's 2 layers.
Half. I've applied for it but had no response.
Yeah. So just on a well-motivated set of people, there's work to be done, and I think so. So that's a key action.
Is that a bit of a comms action though, Chris?
Absolutely.
Because part of it is just go to your general practice and they give you the link to click on.
But it's highlighted a confusion as well, because you can access the NHS app, but there's another layer to then access your primary care records.
I didn't even know about until we had that conversation.
Yeah. So I think there is definitely a piece of comms work to be done there because it is important.
Very eager Emma, go for it, Emma.
Well, it was because it's difficult enough when you're tech savvy. So accessibility around that, I think, is something we need to build in, and people will need some people will need support. But what we're interesting enough doing in our local community hub is doing that in the hub. So we're getting people from the surgery to come to the hub to sit down with, just to volunteer to say this is how you do it. So just making sure we build in that accessibility for people who won't.
And understanding that it when appropriate, it's accessing for members of your family as well when appropriate, such as children, or if you are if you have power of attorney, that's really important, especially if you're someone who might live away from your elderly mother
So
or
Chris,
father.
as you've mentioned your personal experience, I'm going to mention mine. I don't normally talk anecdotes, but I'm going to take the opportunity as chair to use it. My GP practice, I can't remember the last time I spoke to them. I go online, I say what I want to say, I get a text back, or if it's something important, they give me a call. I don't see that service in lots of places. Is that something that is a digital way that we're communicating to people? Only because I searched it out did I find it, as opposed to this comms bit, which is it's there and people don't know about it.
I think if I just go through the key points, I think it's really important that patients have choice, and that they're not just given only one way of accessing their primary care. So that is part of how we need to roll this out.
There in the first place, though. That's my point. How much of that service is available across our practices?
So on empowering patients, it's about access to your medical records,
but it's also about being able to do your own self-referral, for example, to physio, musculoskeletal. And it's also about using our pharmacy difference, so the pharmacists are going to be able to treat some basic conditions: earache, cellulitis, sinusitis. The next element, which I think relates to your point, John, is about improving modern general practice access, and that's about the digital way of accessing and how that is a choice within the way of accessing, to try and go back to that, removing that 8 o'clock rush away from patients.
I understand that. Steve? Let's just Steve ask his question.
Separate question area. It's around dental services, and they seem to me to continue to be under extraordinary pressure. There's nothing in the overarching objectives or the 4 focus areas, which is around dental, and I'm not entirely clear, Chris, on what impact the increase in UDAs will have on actually translating into improved access or any kind of access for some people. So I agree with and support the whole of the plan, but with that question about how do we progress the dental challenges.
This is an NHS England request. And I think in part 2 we're going to talk a bit more about pharmacy, optometry, and dental, where we might see what's important for our sort of Cornish residents.
The one thing I would say on that challenge, though, as we're in part 1, though, is we do need clarity as to whether the dental contracts have been agreed nationally. We're in the process of having them handed over from national down to us, and that transition is still happening, but there are certain things which we were in a briefing session with our 6 MPs fairly recently, and part of that, you can imagine from their perspective, they're seeing a lot of people saying about dental things. There are certain things which we can do with schools, particularly primary schools. It's not always about having dentists, it might be some hygiene inspections and that kind of thing that we do. So Caroline, if you can follow up on that meeting that we've asked for with the MPs and with the leader of the council, to be able to get that in the diary, just to find out with NHS England, where are we at on that dental contract. I think would be just helpful for where are we at in understanding.
Can we also, in all of this, so everything we do now, because I've got Emma Rouse and Rachel Wigglesworth, one in each ear, everything we do now, we should have an equity lens attached to it. So if we are talking about people accessing their primary care records, then largely we can all sort of get on and do it, can't we? Because we've got the resources available to. So the work that Rachel's team have done in place around our core 20+5 wards, they probably are the places that need the greatest support from hubs, that need the greatest advocacy, not necessarily, but probably. So everything we do should be in a core 20+5 delivery phase, including dentistry. So if we do have a fixed budget and if the dental contract doesn't give us what we need, then what's our universal, proportionalistic approach to spending the money, because it needs to be spent against need, doesn't it?
So, Chris, I completely concur with that. So, Chris, if I could move us on towards the recommendations, I think that's probably more helpful. Now, 'cause we had the paper.
So Richard Stevenson had a question because he's here for Mary, isn't he? He's online. I
didn't see a hand up.
No, he put the question in the chat, but I didn't know whether he wanted to ask it. Really pleasing to see that Objective 3 is 100% realised for 23-24 and possibly 22-23. Can we confirm if this is new workforce or redistribution of workforce within the overall system? So I think that's the R's roles, is it?
So I think the plan is to build on that, so to have more workforce, but that is work in progress. Yeah.
Did that answer your question, Richard? Or are you going to pick that up offline?
I guess I was just trying to establish whether we were getting a net increase in workforce or moving bodies around the system and potentially leaving holes elsewhere. That was the key behind the question.
A net increase.
Net increase is what we're hearing. Okay. Chris, are you happy for us to move to the recommendations?
Yeah, absolutely. Just in the key point about cutting bureaucracy and building capacity are the other two key points.
Rachel, before we do them.
Thank you. I just wanted to make a general point. Obviously, primary care, the framework is nationally focused, and they're clearly key to accessing treatment. I think I just wanted to make the point about the capacity in primary care through either the R's roles and other roles, to be really focusing on preventing some of the diseases that we're then coming through the door of primary care. And primary care have got a huge role around that. And I'd really like to be seeing, when we get to a more resilient position for primary care, to be moving forward towards expecting, like in the days of the primary care trusts, where we had a really robust sort of programme of secondary prevention or early identification of disease, and I'm not seeing that in Cornwall. And I think that we really need, as a system, to be able to bring back that capacity in to do the health checks, to do the early intervention, because wherever I'm seeing people who just can't get can't get future appointments, some of it is about managing their conditions and ensuring that those are detected early. And I think that whole piece around early detection and early management of disease needs to be really built back into primary care, something I feel very passionate about, having seen it done well in other places in the past. So just an ambition, really, as part of the must-dos in terms of the access, which I know are directed via government, to really think about this model. And I know that's something that Chris and I have been talking about.
Okay. So, Chris, what I'm sensitive to, before I get onto that, when is it that the deep dive on primary care is coming back? Andy, is it?
I think in conversation, Chair, we've become a little confused over which committee and which board to bring to. Provisional
certainly want the deep dive back here, but let's take it offline then.
It's July.
It's July, isn't it? Okay. So I think what I'm trying to get at there is that, bearing in mind this has to be done by the end of June. All right. It would be very helpful to make sure that deep dive actually explores more of the issues for this board, because they won't have actually all had the discussion on the final proposals. It'll have been through the PCC, I get that, but this board needs to be more cited on such an important topic.
And with relevance to our people. If we go back to Rachel's point, our people in our places and who need a differential access.
Quick.
Very quick. It's again an offer of support. I think there's a huge role here for the Community Hub network linked to their local practices that can support in a lot of this work.
Okay. So we'll move to the recommendations with everyone's support. So note the content of the paper and seek assurance via the Primary Care Committee, the PCCC, on delivering access to the recovery plans. However, the second point is particularly important as well. Empowering the PCC to decide the plan for the submission to NHSE by the end of this month on behalf of the board. So that's where the greater level of scrutiny and drive and development of this is going to be taking place. So I suggest if anybody would like to be part of that, I'm sure Neil, who chairs that, wouldn't mind. But what will be important, Chris, is then, if you can, once that committee has signed that off, can you circulate what has been agreed to the board, such that we, as soon as you've signed it off, we get to see it at the same time that Region National do it as well.
So Martin's put a question in the chat around, you're here, you can say it yourself.
Yeah, I wasn't going to raise it actually, but I just seem to recall we funded some sort of primary prevention, if you like, some funding for education stroke dental education stroke toothbrush. I can't remember what it was in schools for children, I think via either section 75 or 256. I just wondered if that had happened or if there'd been any positive impact on it in terms of dental health.
I just wonder whether we should ask Rachel to come, because we get the DPH report, but then there is the stuff that aligns with primary care and prevention. That when we do the primary care deep dive, could we do the public health, the stuff that we funded based on Rachel's report and the impact that it's had as part of the primary care deep dive?
So Andy and Chris, can you note that then, if that's a request that you're happy with? Yeah. Okay.
I'm happy to do the oral health bit. I think a lot of it doesn't really knit with primary care, Kate, in respect to some of the other health inequalities, DPH, but the bits that fit around, I think, primary care, we should include in that deep dive. I'm happy to pick up with the leads.
Okay, so we have the two recommendations. Everybody happy to support those two recommendations? Yes? Lots of nodding going on. Excellent. So we have sorted that. Over to you, Chris, and to the committee. Thank you so much. Let's move on. You have the floor again, my friend. You're on the draft of the Intermediate Care Strategy and Delivery Plan. The title's getting longer, I notice, but very happy with what it is. So over to you.
This is as building from the last board meeting where we brought the strategy, and this is more of a delivery plan. And I just want to thank Ali and her colleagues, particularly at the council and place, and sort of the collaboration CFT that's really starting to build on this. And I think we've emphasised that this is it's an iterative process and document that needs to move at pace, momentum. So the piece of paper is almost out of date by the time it's written, which is a good thing. I always, I think, like to remind us what intermediate care is, because we can go off into all sorts of directions with intermediate care. So it's the brief intervention to support someone who, mainly older people, either in terms of a medical care or social care input, either to keep them out of an acute hospital or to get them out of an acute hospital more quickly, but fundamentally to keep them independent and healthy living at home. And with that in mind, the intermediate strategy and delivery plan really has to align with the Better Care Fund plan, and that's what we've been working on. So the idea is we'll come back to the board at the end of June with everything aligned, and then we can no longer use the word draft. The four key areas that when you talk about are prevention and anticipatory care, responsive on the daycare, and sort of expediting hospital discharges home, and reable and rehab. And we've broken down sort of the work that's already going on in those areas. There's some key principles that I think it's really important that we are mindful of, and that's supporting people and what matters to them, working on resources at place. So this is very much a place-based delivery plan, and it's to target our most deprived communities, and with reducing health inequalities. We're trying to simplify the access through pathways, and as well as aligning with the Better Care Fund plan, it really has to align with urgent and emergency care plan as well, because a big part of on the day care is actually intermediate care. And as Ali will say, that's not just a clinical model, but that's all of the social care that that sometimes needs to happen on the day. So we realise that as we roll out these bodies of work, some of what will happen in intermediate care will actually be run from other aspects, such as urgent and emergency care. But because the overlap is obvious, it stops us creating siloed type approaches. We're mindful of the timeline and the need to produce and have something meaningful and working for winter. So we talk about what needs to happen now, and we talk about Horizon 1 and Horizon 2. And really that's just to let people know the sort of how we're going to sort of break down the work that for the most part is already happening. And even though something might be in Horizon 2, that's not to say we're not going to start it now. We've tried to simplify the governance so that, again, it's place-based. And the request here is that the the sort of the steering group that where there's representation from all of the partners, we really maintain the momentum, so people really buy into the fact that this needs to keep moving at pace. And again, I just want to thank Ali in that context. So the recommendations are that we approve this strategy, but that there will be an ongoing update that we could bring back to a later board on the 28th of June.
I'm happy to go through the slide deck, but
No.
I would rather take questions.
Yeah, you and me alike. Okay, so let's celebrate the fact that this has been, if ever you wanted an example of cross-system working across all key partners, this has to be it. And I think we should celebrate the fact that we've got to the point where we have a strategy and delivery plan that has got such buy-in by so many different groups of people. I think that's testament to all of your and your colleagues' hard work in doing that. Just to pick up on the point about the timeline of this, we have actually 2 extraordinary board meetings, which I'll touch on later on. The first one on the 21st of June is going to be for the annual accounts, but the 28th of June is when the extraordinary board meeting will formally take any derivative of this, because it's still called draft, and that will then be signed off as our formal intermediate care and delivery plan as a starting point. Like all strategies, they evolve, as you just said. But we need to get this done by the end of the month. So that's the journey that we're about to go through for the next few weeks. So I would suggest, Steve, rather.
I didn't want to interrupt, I just had a question.
Yeah, go for it. If it's okay. Go for it.
And firstly, I think this has progressed really well, and the how this has moved forward since we last had a discussion, I think, is really, really powerful, particularly the delivery plan. So I'm very, very grateful for that. I've got a question, and I think to identify a risk as well, and they're both related. The question is, Chris, do we think this plan and these delivery actions will bring the system back into the trajectory for the number of externally delayed discharges within the hospital setting? As we see in the NHS provider partner member report later on, the position up to the end of May was significantly off that trajectory, and I can update the board that that's continued in June. So that's the kind of key question. But the risk that goes with that, Simon, is providers are carrying significant additional cost with the operation of 40 to 50 additional beds above their plan, whether that be in CFT, RCHT, UHP or elsewhere. And I think that does start to create a financial risk in Q1, even if we address this and this brings us back in trajectory from Q2 going forward. So as well as the urgent and emergency care performance risks, there are financial risks as well associated with this.
Bring that to our attention. I'll let you respond to that in a second. Ali, let's capture your point, please.
Yeah, not a point on the work, John, because I've been quite actively involved in it with Chris over the last month or so as well. So I just wanted to add to Chris's comments, really, to say that I'm really pleased with the work, and I put it in the chat box, but for the minutes, I'm really pleased with the work that we've been doing over the last month or so in partnership. And I really appreciate all the colleagues who've dropped things that they were planning to work on to really focus on driving this forward. And I'm very confident with the conversations we've had and the work that we've been doing that we'll have this finalised by the end of June deadline. And I just wanted to thank Chris as well for his patience in working with me over the last few months on it. So thanks.
Chris.
But I think we have to say that yes to your question, but it's not going to be easy. And it goes back to my point of the delivery plan. Almost within the delivery plan is the Better Care Fund plan, of which there are very specific metrics around no criteria to divide. And I think your point is that the sort of there's been a little bit of recalibration. Is that in terms of there's almost more pressure than what we originally thought.
Well, no, I think if I look, for example, at the June position, the system trajectory was that RCHT would have no more than 70 externally delayed P1, P2, P3 discharges, and at a system level there'd be no more than, I think it was 135. The year to date in June, just as an example, the RCHT position was 92, so 22 higher. And the system position was 181, 46 higher. So whichever way we look at that, we currently and did have in May and continue to have in June significantly more patients in hospital settings, which of course requires staffing, resourcing and other aspects, and have an impact on patient flow, which impacts urgent and emergency care performance, but also have an impact from financial perspective. So the assurance I think I'm looking for is that the plan that we set out, we're confident will bring us into that trajectory that you touched on before. And I ask that knowing that NHS providers are a core part of the intermediate care strategy as well.
So that's the plan, and that's the importance of the steering group having sort of that framework that not only looks at what's better for the person in their home, but also has that outcome frameworks of addressing those measurements to make sure we're on track.
Kate, would you like to add to that?
This is an system assurance piece, isn't it? So I've got the waiters up from yesterday. So if we use RCHT as an example, there's 84 people waiting that I would broadly call in system actions, and there's 31 that are RCHT actions. So the system, we have to take our joint accountability for making sure that each side's doing what they need to. So UHP, there's 31 broad system actions, 2 with UHP, and CFT only 59 system actions, which I think is pretty good from where we have been, with 17 within the gift of CFT. So if I strip out provider actions, we're down around 170. Now, we were at 330. So there has been significant progress made. And the figure that we've got at the moment, the trajectory is system actions and provider actions added together. So I think we might need to split that number some way, but otherwise we run the risk of not having complete assurance around who's doing what in order to be able to get to the place we need to.
So you've heard the observations. Why don't you take offline now how you might revolve it to the next stage on Steve's points. Just capture that. You want to lose such good work between cup and lip at the final moment, but taking Kate's point, we also need to have those sort of metrics in place. So, Debbie.
So this is where now getting to our single version of the truth and the triangulation of the metrics is also really helpful, because on the one hand it's a really good thing that we're seeing a reduction in CFT of the no criteria to reside, and you can certainly see over recent weeks that we've improved the number of discharges from acute hospitals into our community hospital beds. But now, inevitably, those people are going through a period of rehabilitation. So they're actually in active rehabilitation treatment, and you can now see the number of transfers reducing. So we're always going to have some pitching, aren't we? Because when you see the demand at the front door, that sees an increase in admissions, and then there'll be a lag in terms of the impact that's seen in community, and it will be ever thus. But the really powerful piece of work that you've led here, Chris, is bringing us all together and having those conversations about how we best work on this. The other bit, just to say while I've got the mic, is it isn't just about hospital discharge. So I get the importance of it, and we do owe it to all of our communities to improve the ambulance delays and the experience in A&E, but also that work to prevent conveyance, to prevent admission in the first place. And then when people are admitted, that we aspire to the national aspiration of within 5 years, so it's recognition that it's a longer period, people will access effective therapeutic intermediate care services within a day of no longer meeting the criteria. It is an ambition that we will work towards, but we're just not going to achieve it tomorrow, because we've got to really now harness these community alternatives to hospital.
I'll jump around a little bit here because I'm going to jump to the chat bit for a second. Ali, would you just like to expand on your comment there about P3 and that, because you and I chatted about this the other day, and I think it's something we should share with everyone.
Yeah, absolutely. So I've been doing some digging around and getting some data, and it's not data I'm allowed to share for some reason. But I've been looking at our P1 and P3 delays, and our P1 and P3 delays are below the England average. our P3 performance, which is where people are likely to require long-term in a care home, has been sustained improvement and below the England average since December, when we had that big push around Christmas time, around the industrial action, and that seems to have been pretty sustained. And our P1 performance, while it's been a little bit up and down, peaks and troughs, it has actually been still very good performance across our system. And I think in particular, I think the data I was looking at was particularly RCHT actually. So it was actually a really good news story. P2 is still a challenge for us, I think, but we know that we've got a whole load of demand in P2 that we need to understand better for what the community alternatives might be for that. So yeah, I think the teams have done really well. I think it's a really good story around our system improvement work, which has been sustained over a period of time and a period of pressure and time, with a number of industrial actions during that period as well. So I'm really pleased with the team. We will continue to build on what we've delivered so far. The intermediate care strategy can only help us to build on that further. So yeah, really pleased. Good news story.
And Ali, I thought that was better you saying it than being resigned to the chat bit. So thank you for that. Steve, did you want to add something?
Just really briefly, I wanted to put my questions into the context of this is an excellent piece of work. We've seen really good system work. We've seen great system leadership. And the example Ali's just given about the P1 position in RCHT as an example is absolutely right. The challenge that we face is around P2 capacity, but it's in the context of a much improved position, as Kate said previously. So I just wouldn't want my comments to be kind of misconstrued. Yeah. It's about how we can then go further and progress and continue this journey.
While we're being also nice to each other, can I just say, Chris, well done. There is an element of coordinating willing friends to get to a conclusion, which I think you have all done admirably. So if we can just pause that now and agree the recommendations. So,
two things, sorry.
Oh, did you want to add something?
Yeah,
sorry.
So one is John Forsyth raised the question in the chat around P2 capacity. And I think some of the answer to John's question is we're still working through it. So, and our improvement has been made in the context of not making the cultural changes in place around intermediate care, because I come back to the point that Debbie made that on the daycare isn't it a clinical or a practitioner issue. It's not, it's a cultural issue about who can pick things up at which point. So so that would give me more confidence. But the thing we all need to get our heads into the space of is around getting ready this winter for our vulnerable people to make sure that this delivers the models of care that we need.
We only spoke about that yesterday, didn't we? Absolutely. Okay, final comment.
Well, it was just very quickly on Debbie's point about it's not just about what the hospitals and the community beds are doing. Juliet, who's our ICA MD for the West, and I talked to Place yesterday. And again, from a collaborative point of view, they are eager to help out. So they can build on it. They want to own this because they said themselves, we need to keep people and have a different plan for winter. So it's just that collaboration that's actually happening at Place, which is really good. Yeah.
Ali, final word, please.
Yeah, final word. And it is just, it's not, it's a bit of a random comment from me, really, I suppose. But I just want to say that Kate Shields and I have got a pact. And this year, we are not going through the winter that we went through last year. And that is our pact. And we will be doing everything as partners to make sure that we don't, because we are here to serve our residents and our patients. And it was a really difficult, challenging winter, wasn't it? And I know that that's on the back of, a very challenging period with COVID. So I just wanted to make that partnership commitment, really, that we will be working together and mitigating the risk and impact for our residents wherever we can.
Don't forget we have this recorded, so we'll play this back monthly to you, if that's all right.
You don't need to. Kate's recorded it. She sends it to me all the time.
A nervous laughter there, Ali. Excellent. Thank you. Okay, colleagues. So I'm not going to read the 3 recommendations out. You can all read for yourself on this. Are you happy for me to approve the 3 recommendations on this? Yes? Done. Lovely. Thank you very much. So that's the end of that now. We have a comfort break. Before we do, we're running about 10 minutes late, which is fine, but we also have a surprise moment. We have a photograph to be taken. So may I suggest we do this in the running order of natural facilities visited first, straight back, that's the trouble, we're getting old, straight back, and we'll do the photograph and then grab cups of tea, and then we'll try and be back in 15 minutes. I know that's slightly later than planned, but with a photograph, we're back in 15 minutes. Is that all right with everyone?
On your mark.
On your marks, get set, go. Thank you. We are good to go, everyone. So, thank you. And thank you for taking the time out to have a photograph. If you wouldn't mind doing some photoshopping on my weight, I'd be very grateful. I clearly lose another stone on top of the stone I've just lost. So there we are.
I think you'll find that's not a very positive health message, John.
That's right, yeah. Well, I'm going in the right trajectory anyway. It's all about trajectory I hear. That's it. Okay. Okay, so the next paper is going to be led by, actually it says Chris here. Chris, are you leading on the mortality paper?
Yeah, I think so.
Yeah, right. Over to you.
So I'll try and, yeah, and if Rachel hopefully will add to it, but I'll be as brief as I can because I think I've done too much talking already this morning. So I'll take the paper as read. Lot of stats, but the key points I just wanted to bring up are we've now had our second call in the Isles of Scilly mortality group, which was, I think, a really good meeting of where we wanted to really understand how can we use mortality data to benefit the system. And we highlighted that if we can use mortality data as a system to show where excess deaths are occurring, but also put a deprivation, i.e. an equity lens on that, we can pick out some key areas. Then we can ask the system as a whole of how can we look at, for example, there's excessive fractures, so frailty fractures from people falling over, breaking ribs, and then dying in hospital. So instead of the lens necessarily being on RCHT, which they have their own internal pathways to look at, make sure that quality is maintained and there's not an issue there. That's actually probably a system reason, i.e. people are getting osteoporosis, so i.e. we haven't got an appropriate osteoporosis pathway. So the mortality board becomes a really effective tool for highlighting and addressing perhaps where we need to refocus. So the group would like to take away the key areas around cause of death, link it to deprivation equity, and then have sort of more of a targeted plan, and then that feeds back into our clinical reference groups, who then can look at changes to pathways, which feeds up to our clinical prioritization advisory group. So that we felt that the whole sort of circle would fit together. I'm more than happy to talk about the detail in the report, or if anyone's got any questions, other than just to remind me, Shimmy's 100 or less is good, and higher than 100 is not what we would expect.
Very good. I've got some comments, but I'll go last. Martin.
Thank you very much. Yeah, I think you might have slightly clarified this there. When I read it, the paper, which was really good and very informative, I wasn't quite sure whether we were trying to address, I suppose, if you like, short-term issues like changes in shimmy and, what might be causing those, which maybe, wasn't mentioned actually, but things like, delays in ambulances or other sort of short-term factors that are impacting, or as you just described, a sort of more general, we know in Cornwall that we have higher deaths from circulatory diseases, so what do we need to do about it? Is it a bit of both, or is it the latter? It's the latter that seems to be in the recommendations, if you like.
It's a bit of both, but we felt there was far more added value by taking more of a system approach to addressing sort of what might be more medium long term, noting that if you address these issues, you can often impact changes. As Kate often says, if we address the causes of stroke by getting people's blood pressure down, you'll see an impact within 6 months in the system. And we're also recognising the fact that the short-term issues are being looked at under great detail by RCHT, for example, anyway.
There is also about the things that we understand and the things we don't. So intellectually and from RCHT's experience, the ambulance waits for stroke-related death and for fractured neck of femurs going to theatre within 72 hours. We understood that, and we understood the actions we needed to do to make the difference. Whereas the higher than expected mortality rate for other fractures and congestive cardiac failure, we didn't. So I think this is a really good piece of work that has the inquiry behind the figures, and we need to use it more, particularly when we're looking at people who the overall excess death rate might not be increased, but in certain sub cohorts it might be. So understanding why some people don't get access and others do.
Rachel.
Thank you. I think this is a really in-depth piece of work. It's like a deep dive essentially, and I think I really, commend the people, the teams that have worked together to look at different data. And I think I really recommend that if you haven't been able to read the whole report, that you go and have a look at it. So it really explains quite a complex picture around the causes of death, and they, don't just include treatment and services, but of course reflect the health of the population, the age demographic, a whole range of other socioeconomic factors. So it's not just one thing, and I think the report is trying to reflect that it looks at the causes as well as the treatment aspects of what we're looking at in terms of excess mortality. And I think we need to put it in the context which the report does around as well the challenges in England and in the southwest, and a lot of areas also had a particular increase in mortality in the winter period. And this is a challenge, and it's a challenge for Cornwall, and it's been a challenge for some time around winter excess deaths. And a lot of that is actually due to cold homes, respiratory disease, and some preventable factors that relate to that. But I think we really need to recognise that Cornwall has an issue, and it isn't just in relation to delays in transfer and other system service issues, but it is driven by some of the conditions in which people live in Cornwall. So my public health voice wants to say, yes, let's focus on some of the pathways that are identified in the recommendations that Chris has clearly got this group focused on, really support that. And that Chris and I, with the population health group, we're linking it in, as the question earlier said, to the drivers of some of those key conditions, because they are the same conditions that we've been talking about today somewhat, haven't we? Circulatory disease, the cancers, the diabetes, and dementia and Alzheimer's, some of the same things, same causes of those that we need to address. Could be smoking and tobacco. All of those diseases, have an impact. If people smoke, it could be around management of hypertension and early indicators of clinical disease. So we've got to go back to, as well as focusing on the treatment pathways, which are really important to keeping people well and reducing excess deaths, but also the drivers. So as you'd imagine, I've got a lot to say on this, but I really support the approach that's been taken. It's really thorough, and continue to support that mortality group to do system work to look at this, which is the only way that you really tackle it, and through an inequality lens. And I have to say, our life expectancy is not going up. We will expect, it's flattened in Cornwall. The gap is growing between those the most deprived and have the poorest outcomes and the least deprived. It's not a good picture, and that's the same nationally. So we really do need to take this seriously as a sort of real tragedy for the nation in some respects. We are not seeing that continuing increase in life expectancy that we've taken for granted over the last decades.
It's just, could we also, if we're doing this much wider piece analysis, could we also include people with learning disabilities and mental health, just to look at it through that lens? I know we do good work with the leader, which is the review of deaths, but sometimes it would be helpful to feed that in, because then we can link it back to the health checks, people that get regular health checks, etc. So it would just kind of triangulate a little bit of the data a bit more.
Yeah, Margaret, in response to that, having gone through the paper last week with the authors, we picked that up. So we are going to bring leader and mental health suicide into this, and ask if Chris's group would pick that up, because it's really important that we've got an equal focus on that. Yeah. Thank you.
I don't like it being shoved off on the side.
It needs to be brought together.
Great. Thank you very much for that.
Thank you. And although it's a helpful summary, SHME and things like that, it's hiding a whole multitude of dynamics underneath. So, okay. So, any other points?
And it would be great if we do some triangulation, because I'm just thinking, if you've got cancer, the earlier you present, the more likely you are to survive, because surgical intervention is usually the best way of having a great outcome. We know for some of our communities, they are late presenters. So, and it goes back, Rachel, in terms of the understanding that we've got through your team's work around where different forms of deprivation sit. So it's how people access both stuff that will stop them getting poorly, but once they are becoming unwell, how quickly they get into services. So we might need to think about how we look at our waiting lists, how we look at, access to preventative care, and that then takes us back to the localism agenda, doesn't it, and how we're supporting people in place.
So Kate's finished on the point that I just wanted to make is around the place-based agenda here, and actually there are probably communities that have different mortality trends and different health-seeking behaviours, different health referral behaviours. It would be really valuable to see some of that in this as well. Notwithstanding, this is a really powerful and valuable piece of work. Death touches us all, and it tells us so much about how we live our lives. So more, please.
So is it your plan, Chris and Rachel and colleagues, to come back with some sort of map of the area that tells us hotspots, or how are you going to present this back? Because it's quite a general topic, and taking Margaret's challenge there, how do we focus in on an area and get the real, where are the top priority bits of this? How do you plan to come back?
I think that the mortality group is to look at specifically the mortality data, and then it asks those questions for which might come to if we're picking up Andy's point that there's the variance of stroke, then we would ask the stroke clinical reference group to look at that and have an equity lens on it.
Okay, thank you. Rachel?
Yeah, just to share that the Director of Public Health report this year is focusing on health inequalities and the drivers of some of that, and it will include quite a lot of data and information that I'll be bringing both to the Health and Wellbeing Board in an early form and to ICB when it's available just after the summer.
And although it's a difficult topic, I know we always pick up on the bad news stories, but in the paper where it talks, Steve, about RCHT shimmy being below 1, we should recognise that's, given the makeup of our portfolio of users, shall we say, that's a interesting story. And Chris, this is a rolling average, I take it, these 12 months, or does it only ever finish on the December window? Why are we half a year behind in terms of the stats here?
I can give you a sort of a high level answer, but it's just to do with how new the data is and how we get it received.
Is it your expectation it'll be more up to date than 5 months out of date?
I think there's.
I get that. I guess my question is it something that we're in control of? No, it's not. No. Okay, fine. Okay, so it's national reporting is. I'd forgotten that. Okay, fine. And just give us 20 seconds on who sits on the mortality group. Which colleagues across?
I can
just roughly.
So it's both trusts. Yeah, both trusts. I think if we haven't got place, we need to have place.
Like an invitation list, please.
And public health.
I think that's why I'm unpacking it, really, based on your question. I suspected that there might be an issue there. So could I ask you to circulate to all colleagues afterwards who sits on the mortality group? And if you've got an issue or concern, raise it with Chris, and at least we're all sides who sits on it. Does that work?
Can I ask a technical question that you might want to answer offline? And Rachel, you might know the answer. So isn't there an advantage to looking at hospital standardised mortality rate alongside SHIMI, that I can't remember what it stands for, because the hospital standardised mortality rate is based around specialties within organisations and start to tell you something around practice. Not always, but something around practice. Whereas the SHIMI is around the general health indices of the population, and that reflects the who gets into treatment, who doesn't, where prevention sits, where it doesn't. So because it says here that we'll agree SHIMI is the primary mortality metric for analysis, I don't think we can do that because we will be held to account by NHS-INE around specialty-based HSMR.
So let me think about it and give you a more factual answer.
Okay.
But I think that was an NHS England request to start using SHIMI as the main data.
Okay.
Okay, thank you. Let's before I get to the
Sorry, if I could just briefly comment, just to note that provider organisations, of course, do review HSMR and SHIMI
exactly
in detail through their quality committees and through their boards.
That as matter arising, otherwise there'll be a question that then we don't answer next.
So if I can make a general observation before we get to the recommendations. Kate, you and I have spoken about increasingly board reports. We need the detail, We need the substance. But I think there is an extra skill set to writing an executive summary that maybe we just need maybe some help on, or whoever's writing them might need some help on, etc. I particularly as we're in public, SHME, HSMR, blah, 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 etc. Just not quite sure it lands quite easily with the normal person on the street who would understand quite whether this is good, bad, or indifferent. So again, Lucy, I would invite you to read some of our papers and go, would most people get this who aren't clinically trained? I'm not trying to use that as a metaphor for non-execs don't understand it and get around it by that way, but I do think there's something here about trying to explain it from most people's perspective. If we could be more concise, more pithy, little phrase, that would be really helpful. So I think that's a general comment, and I think it comes out here because I didn't see the HSMR in the summary making that point, which I know about and Steve's just raised, and yet it's not there, and it's another indicator of the top two ways in which we would review mortality, and it's not even in the executive summary.
Can I make a suggestion? That, this is Molly's first meeting as an observer.
Yeah.
Maybe Carolyn, Molly and I could talk about getting some board. So if you've ever worked in the Department of Health, you'll know that 2 sides of A4 needs to tell your story. And then if people want to, they'll go deeper into the appendices. We need to learn to tell our story in 2 sides of A4 in a way that people understand. So maybe we could commission a piece of work around board report writing.
I think that's a fantastic idea. Okay, so coming back to this paper, let's go to the recommendations. We're asked to note the mortality position and support Cornwall Mortality Group, which I think we can all sign up to. Request that Cornwall Mortality Group focus on the 12 months, exploring factors across the whole community. And this now needs to take into account Margaret's point, if you'd be so kind. And Caroline, if you could capture that point that Margaret's made as part of the recommendations, please. And I think we would all support the bit about and in the inequalities gap in life expectancy. And just think about how you're going to come back and articulate how you're cracking that. Request that Cornwall Mortality Group undertake a deep dive into the causes. We'd all support that. When do you think you'd be able to do that and come back and tell us the answers to that?
I think it'll be like the group meets every 2 months, and it'll be a rolling. So I think if you really want a genuine understanding, I think you need to give that
2 sessions.
2 sessions.
So what's that? So that's
4 months.
4 months from now. So sort of October window. So you're happy to forward plan it. So Caroline, if you could in the forward plan, please just put in the next update on the mortality. That'd be great.
And we'll have Rachel's Director of Public Health report by then. So the focus that she's got around inequalities would be really helpful. Maybe it could be a joint piece, Rachel.
Yep, happy to do that with Chris.
Okay. And the last note about the suicide rate remains an outlier. I think we can all agree to that. And the recommendation about the Common Suicide Surveillance Group to ensure systems learning. How's that plugging in, Chris, into your group?
It's at the next group meeting, yeah.
Yeah. And one final observation before we conclude the recommendations is, can we also look at the analysis of the dates where mortality was the highest? Was there any particular issues and the rationales behind them? I know it's a 12-month issue, but is there anything hidden in there, even within that 12 months, that we could tease out? That'd be really helpful. Okay, so are you all happy for us to endorse the 4 recommendations? Yes?
I think it's a hand up.
Oh, was that Carol? Carol, go for it before we conclude.
Thanks, John. I just want to make sure that the timings that you mentioned there, comes back to QPOC first. This paper came to QPOC, so October might be a bit too soon for it to come back to board. So if we can just leave those dates open until we align it with QPOC.
Yeah, thank you for pointing that out. So Caroline, if you could capture this, please. If you can do October, do it, but it goes through QPOC. If you can't, we'll make it a month afterwards. But the principle is it needs to go through QPOC first before it comes here. Everybody happy with that?
Mm-hmm.
Yep, lovely, done. Thank you very much, everyone. That's that paper, all agreed. So let's move on. So now we've got the section on updates from committee chairs, partner members and participants. So let's go on the screen first. Carol. No, it's coming next. Yeah, all right. Carol, you go first. Anything from your two committees that you'd like to update on?
Yeah, thank you. Thanks, John. The QPOC met in May, and I've outlined the key areas that we discussed, two of which are on the agenda today, actually, the SEND presentation and also the mortality update on trends. It was a good meeting. I suppose from a forward-looking point of view, what we're not discussing yet is the system oversight framework for Q4. So we need to make sure that we're aligned on those subject areas. And so I'll be talking to the team to make sure that we've got that on the agenda next time, just so we're across all of those issues. There isn't a paper on Citizens Engagement and Equalities Committee because we met yesterday. The key update there is the engagement strategy. We had a draft yesterday and that's coming to board in July. And also we had an excellent conversation around journey mapping, which isn't for conversation now, but if I asked everyone to give an explanation of what they thought journey mapping was, I reckon we would get multiple answers to that question. So one of the things that we just need to determine is, what does journey mapping mean across the system? How are we going to go about it? How are we going to resource it? Where do we start? And perhaps we cited yesterday some early, perhaps we take an example of winter wellness. Maybe we look at that as an example area, but that'll be something we'll come back to board with. Thanks, John.
Thank you. And just before we move off on one of the points you made on quality, on item 14, we've actually got the new draft integrated performance report. So maybe some of that might be plugging into some of your questions as well. Okay, cool. Martin.
Thanks, John. Yes, again, no written report. We only had the audit committee this week, a couple of days ago, but I'll just raise a couple of things if I can, John. A couple for information and one maybe slightly more formal. So for information, we had the Statement of Internal Control annual report from the internal auditors, which ranked our organisation as reasonable assurance for the year, which is good news, I think, in terms of how we set up the annual report and close the year. We also had a first look at the annual report for the organisation for the year, and particularly looked at the sort of governance element, which the audit committee is tasked with having a look at, and we were reasonably assured that that is coming together nicely. We'll come to the board as part of our extra meeting, I think, later on this month. The one thing that we probably ought to look at, or I wanted to mention to the board, was we looked in a bit more detail at information governance and our compliance with the information governance toolkit. This is something that the board has to be cited on, but we're sort of looking at it on behalf of the board, if you like. So just to note that we have looked at that. The auditors will still go through our submission before it finally gets submitted next month, and we'll receive the report on that next time around. I suppose the only other thing to mention is we've talked at the last audit meeting and at this audit meeting around how, as the audit committee, we can help with assurance of this year's annual plan. Yep. We've agreed, there's a bit of sort of two-pronged attack with finance and performance, but we've agreed that the audit committee will also see some of the cost improvement reports and work out how we can get some audit assurance on that. We started to talk with our internal auditors around how we get some combined audits going to give us sort of joint assurance on how we're doing against those plans.
Oh.
Yeah, thank you. Workforce Committee hasn't actually formally met since the last board meeting, but we've got a meeting in week after next, and we will be focusing specifically around trying to really explore in detail the kind of cross-relation between the numbers of increase in terms of the workforce, the vacancies, and agency spend, and seeing how those things coalesce together. So we're really going to be asking partner members to bring information to those sessions.
So one of the themes that you shared with me on the back of that is the information that we're talking to the national team about in terms of the amount of workforce that we've had since 2019. And as part of the soft letter and things like that, our focus on agency is how we join all the dots on all of that up such that everybody is content with the analysis that's underneath that. Yeah. So that's the piece of work you're trying to do collectively with everyone. That's my understanding. Is that right? We're
going to be adopting an appreciative inquiry approach where people bring the information and data that they've got, and then we can start looking at what some of the issues and solutions are.
Very good. Okay.
So that was raised at the Devon board yesterday, because there's a sort of a shorthand narrative that we haven't got enough people. But when we reflect with our 21% higher whole-time equivalent and 27% higher pay bill for Cornwall, that's reflected through Devon as well. Their numbers are different, but there is an increase in whole-time equivalents and cost base. So there's something we need to get underneath through the workforce committee around what's driving that. Because if we're not going to get any more people than we've already got, how do we use the talent and the resource we've got to meet the need of our population?
Just for the board's awareness, this it goes beyond our local patch, this issue. I'm part of a regional group that's going to be same issue on a wider basis. I'll report back through workforce committee and to here in terms of the findings on that, but there's some joint work being done between CFOs across the region, which the first meeting is next week on the 14th, so we'll keep everyone updated on that.
Great.
Could I just make a plea that we're not being asked to provide additional reports and information, because at the present moment, Steve and I, as you know, the two main NHS provider organisations share a dual chief people officer and a dual chief nurse. So through that, we are working on aligned approaches to workforce sufficiency and also workforce competency, ability and development, recruitment and retention, and agency reduction. We have got, however, some really wicked gaps. So structurally, we have a national and also local shortage of registered mental health nurses. So although we have been creative in recruiting people into peer support worker roles, nurse associate roles, apprentice roles, and recruiting people onto those degree programs, the headcount goes up, but the work that they can do in training is less. So there are some nuances that we need to truly understand, and we've got quite a lot of that understanding. So if we could present it in a way that makes sense to us and then engage in the appreciative inquiry, I think that would be massively helpful.
Excellent. Okay.
So there is, so if we were ever to have a joint committee, this is the grist of a joint committee. So it's not handing stuff over for somebody else to review. It's the conversation in the time around what the numbers mean. Because I don't think there'll be any tolerance of spending more money, which is what increasing headcount is. So we are overspent this year with a plan to bring it in. There's an expectation that we would need to do more next year. That's about people. So some of and I don't know how I can say this without sounding awful, but as part of our confirm and challenge, we might have individual issues, but we have to cope within the numbers that we've got for the money. How we spend it is a different matter.
Yeah.
I cannot disagree on the money point, but also we do, providers are measured on their safer staffing metrics, and the CQC, who are another regulator for us, will have a very clear view about the work that we're undertaking to ensure safe staffing in all of our main services. So we've got to balance the two.
And one of the things I'd like just to add, rather than have the debate too much now, is there is an assessment of a chart that shows 27% increase in WTE, 21% increase in the cost of doing it.
Around, isn't it?
I thought it was that way.
21 and 27.
Yeah. Since 2019, with no more workload, and skill mixes haven't changed in that period of time. So the challenge is that a correct assessment, or is something changed since then? I don't know. What I'm trying to say is that we're being asked the question, this piece of work must go away and understand whether it's right, or if it isn't right, we can articulate back what's happened. But to say I don't know is something which we place space we can't be in. We need to unpack that, understand it, and have a defendable position, or accept the fact that things have changed, and if so, why and what drove that, and then we can articulate.
Saying
that.
I don't know, John.
No. I'm just saying that. No,
So-
I don't know. So
the headline figure sort of says the opposite to what Debbie's just said, because it's 21% more people, 27% more spend. So it would suggest at first look that we're paying more people, more money. So there's a grade drift within the numbers. So we need to understand what that means. And you might have great understanding within a provider setting, but we don't. So we need to look at how we pull that together.
Yeah, it's 27%. It's 27% in expenditure.
Yeah.
And 21% in
numbers.
In cost. In numbers. Yeah. Exactly right. That's exactly right.
Thanks. I was just going to add, Debbie, you would have seen the dialogue going backwards and forwards about our commission turnaround support. That's exactly the piece of work we'd expect them to be really clear about and help us find that way forward and the balance between staffing and money. So I genuinely think we'll get more clarity working with each other on over the next 2 months. Thank you.
Okay, so really helpful insight from Tarn there. So let's move on to the partner members. So I know we're running behind schedule, but I think this is important stuff. So I'm going to start with Steve because I want to give you a bit more space and time to look back on how we're doing and share some of the thought processes from your provider perspective, please.
Yeah, very grateful for that, John. And with apologies for the timing, board members, we did share an additional paper yesterday, so I'm just going to refer board members' attention to that, which is the supplementary information on ambulance handover performance. It's a one-side slide that shows last year's ambulance handover performance at Royal Cornwall Hospital compared with this year's performance, and provides a similar comparison on Category 2 ambulance handover response times last year and this year. And that was the area particularly I was going to focus on, John, if that's okay. But of course, happy to take any questions on those. One of my reasons for sharing that yesterday is there was some media coverage yesterday on the systems or organisations that have been placed into Tier 1 of urgent and emergency care oversight. And of course, Kate refers to that in her Chief Executive's report. But with that media coverage yesterday, I thought it would be helpful to provide an absolutely up-to-date position from a Royal Cornwall Hospital's trust perspective. So you see in the slides that I've provided, the blue line is last year's performance and the orange line is this year's performance. So the last complete month we've got is May 2023, and you'll see in May 2023 the average ambulance handover delay at Royal Cornwall Hospital was 43 minutes. And if we compare that to May 2022, it was over 200 minutes. So there's about an 80% improvement for the month of May 23 compared to the month of May 2022. When we compare the average performance throughout the last year, 22-23 was 178 minutes, and the average performance year to date, you can see, is 67 minutes. So significant improvement, not just in the month, but in the year to date performance. I would have to caveat that improvement, that whilst it's a significant improvement, we do need to significantly improve that further. So I don't think any of us would have any other intent other than to see that increase even further. Nevertheless, that is a significant improvement. And just to give a little bit more detail and context on the position this year so far, the performance during the month of April was 99 minutes. The performance during the month of May was 43 minutes. And the performance in June month to date up to the 6th of June was 36 minutes. So we can see month by month we're continuing to see an improvement. The year to date position this year is, as you see, 67 minutes, and board members I'm sure will recall that we submitted an operational plan trajectory, and that trajectory was 78-minute performance during Q1, improving to 40 minutes from the start of Q2 onwards. So year to date rather, we're within that trajectory that was set in discussion with NHS England. So that's a positive position. But perhaps more significantly, the performance during the month to date in June is now within the Q2 trajectory, which was 40 minutes. To be absolutely clear again, though, we need to improve further and continue that journey. We would be seeking to achieve handover delays of no more than 15 minutes, and actually for those handover delays to be the exception. The case is to have no ambulance handover delays. But given that scale of improvement and given that trajectory, I thought it'd be helpful to have that additional information. Now, what we don't have is the national report that we had previously that showed week by week the comparison between the cohort 1 and the cohort 2 trusts. That reporting mechanism has stopped for the moment, so I don't have that comparison to share with the ICB board because it's not being provided currently. I'm not sure what the replacement mechanism is going to be. I think the tier 1 and the tier 2 arrangements are still being finalised. So John, as soon as that reporting mechanism is available, we can provide it as we have done previously. But the reason we're not providing it is it hasn't been provided to us, although clearly what we do have is the local performance. Colleagues across Royal Cornwall Hospitals NHS Trust, across SWAST and across the whole of the system are working incredibly hard, and as we know, there are detailed improvement plans in place that are progressing really rapidly to address that. The second graph that you can see is the category 2 ambulance response times, and there isn't quite as strong a correlation here in the year to date so far. What we've seen previously is Cat 2 ambulance response times generally followed pretty closely to the ambulance handover delay times. We're not seeing that quite so clearly, although the data for June is only for the first 6 days of the month. So I think that is probably an area that we don't give too much focus to until we've got the full month's data from June. I would expect, I'm sure Tim would as well, that category 2 response times would improve and follow any improvements that we have through the ambulance handover response times. This graph has only shown those 2 indicators, so it's not showing emergency department 12-hour performance or emergency department 4-hour performance, which of course are key indicators for us as well. But I thought these were perhaps the most significant indicators to share. Given that I only circulated that slide yesterday, I'd be very happy firstly to take any questions on kind of the content of that slide and that information if there are any.
Really helpful update, thank you. Debbie.
First of all, I really welcome the clarity on the information. And although this is a complete system effort, Steve, I would like to particularly congratulate the staff in RCHT for their leadership in this space. This might seem a slightly random question, but I'm facing my second summer in Cornwall now as a chief executive, and I was really quite struck last summer by how much pressure our urgent and emergency care services came under, such that colleagues were saying to me, well, in Cornwall we have 2 seasons for urgent and emergency care, so we can't talk about winter planning, we talk about seasonal planning. So given that we've achieved these significant improvements during a period of holidays, 3 bank holidays unusually, but I'm anticipating 6 weeks of the summer holidays coming up, and I'm wondering what planning we're doing, and it could be a question for you and Susan about how can we sustain this flow, particularly the out of hospital onward care flow during the season that we're planning for.
Susan, just to respond, and then Steve.
So thank you, Chair. We picked this up at the SCC meeting, the System Coordination Centre meeting this week, that you're quite right. We have another season that's about to hit us, and we've also had industrial action in amongst all of this as well, which is just worth pointing out, and that's continuing. So not only have we got summer, we've got another period of industrial action. We've asked our EPRR colleagues, Debbie, to pick this up because we were in a rigour before COVID of doing seasonal planning, winter planning. We did a system tabletop exercise, and we all went through each other's plans just to ensure that they dovetailed. There were no negative bullwhip effects. So we will do the same. And just if you wouldn't mind, Steve, we've also picked up some of the issues around the category 2 mean times, because we know when you're looking at it in the immediacy, the fact that we've had very little ambulances queuing at RCHT of recent weeks. We've had some at times, usually early hours of the morning. The Cat 2 mean time doesn't necessarily correlate. So we know we've had the perfect week with RCHT. We're going to do some feedback through the SCC, but also we've asked for a deeper dive around the Cat 2 mean times, because it's really important, because we know that's where our national colleagues focus, as well as the handover times. So we're going to do a deeper dive. And in fact, we've had Christian instead of Jeff this week for SWAST, and he's certainly up for doing some of that work with us.
Good. Can I bring in Emma first? Emma, on the screen.
Thanks, John, and Steve in particular. I just it was more of a triangulation of information briefly, just so that colleagues are cited. Kerno LMC, along with all the other LMCs that cover the Southwest, so SWAST footprint, met yesterday. We've started to have a regular catch-up meeting together, given the issues that we all know about, and I think it's really fair to say that when we presented in that hour meeting with a snapshot of the information right across acute providers across the Southwest, it was brilliant really to see that sustained green shoot sort of progress, as John has said, and I think I was really interested to hear SWAST colleagues talk about what their views were on the reasons for that, and I think, you know, the Perfect Week very much played a part in all of that. So I think the thing that I wanted to flag there is just really that it's lovely to see that kind of triangulation of that positive work, but also on a slightly more challenging note, not only obviously, as Steve said, is there the sustainability issue which we all need to be aware of, and try and collaborate to support where we can, but the north and east position obviously is much more challenged still, and not looking as positive in any way for the folk who are in the north and east and facing Derriford. So I just wanted to make the point that it was really good to hear that message through SWAST colleagues' lens, really, as well as through this board. So really helpful.
Thank you. And in fact, I'm going to bring Tim in a second. So Tim, just before I say, give you a chance to comment, just want to congratulate SWAST on the appointment of their chair. I have to say, in the regular conversations I'm now having with Stephen, it's feeling an uplifted kind of conversation, I have to say. I don't know what other people are feeling, but I'm certainly having a spring in my step every time I finish speaking to Stephen. So just pass on my thanks to him. So can I ask you to give us, what is SWAST's perspective on what you've heard from, well, for example, Steve's comment there, from Debbie's comment, but also when we remarked earlier on from Ali about P3 kind of territory too. How do you think we're actually doing from your seat?
Yeah, thank you, John. And from a system perspective, looking at everything, it is all moving in the right direction. And perhaps where we've seen back end of last year, we saw a couple of good weeks. This is now looking more like a sustainable trend, which we'd want to acknowledge and thank everybody for. But also, of course, to Susan's point, to make sure that as best we can to plan for the coming summer, which we expect to be busy. Part of the misalignment of the Cat 2 performance going up, certainly in May, and not tracking down as much as we might think to, with the handover delays at Trelisk there, is broadly linked to the fact we've got 3 bank holidays and we had that half term, so it was busy generally, and of course, you know, that's part of it. The hospital handover delays are also impacted by the amount of conveyance that we do, and we still remain the lowest in terms of our conveyance to ED of any English Ambulance Trust, so that helps us through that. Of course, we never know necessarily day by day quite what that's going to look like, but our percentages remain consistent in it. The handover delays to the numbers that Steve's talked to are I'd say really encouraging in towards where we're getting to, and we're getting that anecdotal feedback through our crews as well. Susan mentioned Christian. I'm in dialogue with him around what that looks like. And crews are noticing a real difference. So that's feeding through not only to a better patient experience at that, if you like, that interface, but also a better, from a SWAST point of view, a better experience for our clinicians, our paramedics and colleagues that are able to then turn around and get to the next people that we need to go and see, and therefore reduce that risk and that harm in the community. So it does very much become a virtuous circle. Probably finally, I would just finish on saying though, we do need to strive for the national standard, which is 15 minutes for a hospital handover delay, and a mean of category 2 response time of 18 minutes. In saying that, there's a lot of work that we're all doing, and SWAST has got a big investment plan that it's going through this year to get us towards that. And we are looking at a sustainable Cat 2 performance across the whole of the organisation of 30 minutes as being, if you like, that signal measure. And those plans are predicated upon an average hospital handover day of 40 minutes across the whole geography. So, you know, all that is modelled in and we, like Steve, will be continuing to track this on a provider basis, on a system basis, and a regional basis. And certainly I'm happy to take back to Stephen Otter, our new chair, how you found the interactions with him. Thank you, John.
So, just trying to conclude, Richard, you're on screen as the Vice Chair of RCHT. Would you pass on our thanks to your Chief Executive and their executive team? I'm sure you wouldn't like me to do it publicly in front of him now, so if you would be kind enough to do that through your board. It is a system solution, but without the drive and commitment, Steve, through you and your executive group, we would not be hearing that kind of debrief. So just wanted to say thank you, and do pass on our thanks more openly within your own board. Please, Richard. Thank you.
Absolutely,
So shall we move on? Yeah. Okay. Debbie.
Yeah, so I'm going to take the report that I've written as read, but as I started with my report, Chair, it was very timely actually, because we'd already wanted to bring to the Integrated Care Board's attention the National Partnership Agreement on Right Care, Right Person. So the data's in the pack. I'd like to really just applaud and highlight the very positive and constructive working relationships that we have with Devon and Cornwall Police. They have been very proactive in their work with us, as has the new Chief Constable. I omitted to put in my report that Steve also attended the recent roundtable with the Chief Constable. We've already got plans for a follow-up at senior leaders roundtable, but in the meantime our operational teams are working very, very closely on continuing the interface work. Such is the variable response across the country from different systems. NHS England are surveying all integrated care boards on their preparation for the introduction of Right Care, Right Person, and our teams are working on that return, and we're working on that together with Devon. But I would just like to say that we work so closely with the police. It's not just about mental health crisis. They support us in a range of other matters, and we have their continued commitment to work in partnership with us on implementing this agreement.
Thank you. I take it everyone is clear on Right Care, Right Person. Just bear with me. I think it's an important thing. It's a national initiative, so it's not just a local thing. And I would like to concur both with the Police and Crime Commissioner as well as the Chief Constable. I think the relationships are excellent. So I just wanted to support that. Thank you. Martin.
Second, that was great to see the report. Thanks. Just to understand, I suppose, how much collaborative working there is, and to sort of see that people aren't necessarily pulling up the drawbridge and saying problem to you. It's more, how can we help each other here? And it's clear that there's lots of mutual aid going on with other agencies, which was great to see.
Very good. Okay, moving on. Thank you, Debbie. Ali on the screen.
Hi, thanks, Chair. I'll take the report as read, just a couple of highlights if I can. Some excellent work going on between CFT and Adult Social Care to smoothly and successfully transfer the adult mental health, adult social care services back to the council. And it's been a relatively smooth process. Debbie and I will be holding some regular assurance meetings as well to make sure that it lands and embeds well, but also that we continue that partnership working and that we don't lose those benefits for our residents. That we continue in adult social care to drive down the length of time that people are waiting for their assessments and services, and we continue to see some improvements there. You'll see also in the report that we've done some measurements based on this time last year and this year, and that we're now supporting an additional 309 people, or we were at the time I wrote the report, with a package care to live independently at home, which is excellent. And also our reduced reliance on care home beds for people. So we're supporting a net reduction of about just over 100 compared to this time last year of care home beds, which means they're available in the market for flow as well. There's also some summary in here on the National Childhood Measurement Programme, and I'm just going to confess that if you've got any questions on this, I'm not going to be able to answer it. So I will have to defer them to Rachel Wigglesworth, who's not with us at the moment. She's had to dip out for another meeting, but I will get Rachel to give you an answer. That's all. Thanks, Chair.
Anything?
So take the report as read. I just thought I'd highlight something that possibly wouldn't be considered in the primary care partner member. This month, is Active Travel Month for Cornwall, and it is National Clean Air Day on the 16th of June. So the ICB funds a Cornwall Greener Practice, a small number of people to improve climate resilience within the area. So I'm going to just do some pieces for them, and I've talked with Lucy about how we advertise Active Travel Month and National Clean Air Day, and I just put it out to the ICB as a positive thing.
Emma?
I was going to pick up on that, so that's brilliant, and that work is being done in the voluntary sector, which is fabulous. And I wondered whether for the forward plan we might want to do a bit of a spotlight on environment and climate at some point in the future,
Yeah, I think
building on this work.
I think we've got something on it either in part 1 or part 2, but Caroline, can you remind me when we get to the forward planning session at the end of the day that we have got that? Because
And next week is Big Green Week, in case anybody wanted to get involved in any kind of environment.
this is your moment, by the way. So on to your partner update. Go for it.
So mine was done in kind of highlight version, but I did just want to identify just a couple of statistics, because I know we've talked about the gateway and the community hubs quite a lot over the time, but we have now got the combined data for the 5 and 6 months of their implementation. So I did just want to kind of identify a couple of statistics. So in the 6 months, in 5 months, the gateways had 12,600 contacts. That's nearly 2,500 a month, and really picking up the number of personalised care and support plans. The community hubs have had 41,000 attendances from October to March over those 6 months, and we've just yesterday landed the broader evaluation for the community hub network, which is taking us beyond the number of people who've been there. So I just thought I'd give you the early doors on a couple of headlines there. We really feel like, and this was a piece of evaluation done by an external provider, Helpforce. So it's been done externally, working directly with 11 hubs in the network. 99% of people saying that they had their expectations met or exceeded. So that personalised approach is really working. We're seeing 93% saying hubs have improved their mood, 85% saying that their interaction has improved their self-esteem. What's really interesting is 50% of people attending the hubs who were surveyed are saying that they would have otherwise approached a healthcare provider in some way, shape or form, of which the majority of that is saying they would have gone to their GP. So it's really interesting to see, and I know that's a person saying what they would have done, and it's really difficult to quantify that, but I do think we are starting to really build up that evidence base around what the community hub network can do, and so that's 25,000 people potentially who haven't at that point in their lives come to any of your doors. So I think that's a really exciting platform to build on, and we're just finalising a few sort of I's and dotted and T's crossed, and then I'll be able to circulate that to the rest of the board.
Very interesting.
And the other thing I wondered if we could do at some point in the future is this, come back to the King's Fund report. So it's a latest report around addressing the barriers to working with the VCSE in integrated care systems. There's some great recommendations in there, 3 key areas that won't surprise you around how we commission, how we design services and deliver, sustainability and funding, and data intelligence and insight. So I think there's some great work that we can build on.
Did speak a few weeks ago actually about, it's been a year since we all got together.
Yes.
Down in Heartlands. Just wondering whether there might be an opportunity to get that group of people back together again.
I think this is probably
That's what I
something
meant,
that we
for
could coalesce around on that. Yeah,
And
absolutely.
it needs to be reflected in our financial strategy, in our business intelligence function, and in digitisation. So we know from KPMG, don't they, when Mark Brentnell came to talk to us, if we get population health right, if intelligence, if we get digitisation right, and if we fund in a sustainable way, we'll see changes. So
could you catch up?
Yeah.
Okay, and maybe feed all of that
Yeah.
into that. Does that work for you?
Yeah.
Okay. Emma?
Thank you. Sorry, I didn't get my hand up early enough for just adding on to Andy's piece earlier. It's just a flag to the board that, and it feeds back to Steve's report as well in terms of agenda for change pay award, just a really quick flag to say, for those who don't know, that the costs increase isn't provided to general practice for their team. So either that, when GPs do adopt agenda for paying for change pay for their teams or for inflationary uplift. So just to be clear, that's a significant reason why nationally there's been a contract in position, significant reason why the BMA rejected the contract for the year. So I just want to sort of bring up the risk somewhere of significant destabilisation, because we are now getting a number of reports from practices that staff pay because there isn't an envelope that includes those uplifts is causing significant stability issues. So I just wanted to make that point and bring that in so that everyone was cited.
So let Kate respond, please.
So can we pick that up as part of the primary care committee? So Chris and Neil, and maybe we could do a bit of an impact assessment across Cornwall, because it's becoming really useful sitting on the Devon board, because they were raising this yesterday around their practices. And it would be great if we were aware of who we need to support and why, if we could take that through the committee.
Okay, thank you. Mary?
Question for Emma. Sorry. Do your figures, your stats, include the community groups that are setting up? There's churches and presumably they don't. No. So there's obviously a bigger number. Yep. And it would be really helpful, I'm sure, for some of these groups to know whether you go at least for signposting literature, things like that, because I don't think that's happening. And their opening hours are extraordinarily limited. I know there's at least 3 in the village where I live, and they've tried to make sure they open on different days. And obviously it's eased off as the warmer weather has come in, but it's just an extra stat that we ought to be aware of, even if we can't get numbers.
Thank you. Kate?
And again, from the Devon board, one of the non-executive members of the Devon board, Sheena Asthana, who's a principal researcher, and they're asking for support around a piece of work to look at the Economic and Social Research Council to build a consensus around key economic, community and environmental issues. So I've said I'm going to put you in touch with her.
I've already done that.
Oh, lovely.
Yeah.
You're already on the case.
Yeah, the hubs are already involved in that.
Excellent. Thank you for that. Now, Jane is not on the call.
No.
Okay. So I think that's that group done. So, colleagues, we're running slightly behind schedule, but with your indulgence, I think it was helpful to have had some of the debate on certain other things and the update from Steve and the photograph and a few other things. So we'll try and get through the next section and try and catch up if we can. So on the integrated performance report, which is work in progress, Susan.
I'm going to hand over to my colleague Kate to take this one.
Thank you. Thank you, Chair. So in front of you, you've got the performance report. I would argue perhaps it's not an integrated performance report as yet, and is definitely work in progress, which we're hoping to conclude over the next few weeks and get this into a better product, I would say. The second point I would like to make is just to remind colleagues that it's March. So some of the data we've already heard from Steve, the great improvements in urgent care and ambulance handovers and the CAT2 responses, which isn't reflected in here. There's some big headlines in here, like the NHS constitutional standards and the metrics are not being met for urgent emergency care, for elective and what have you. But I think that doesn't reflect the really good work that's going on underneath all of that and the improvements that are being made. When you look into some of the detail, there's various metrics are demonstrating an improving position. And I would just point out, and it's not flagged up in here under elective care, for example, there's an improving position there in the 62-day cancer position as well, which I think is a really good green shoot at the moment. So that's really good. So I'm probably not going to go into any more detail of any of it. Happy to take questions, but I would just like to reiterate that we are going to be developing the integrated performance report format over the next few weeks. I'd like to develop a bit of a sort of subgroup with some colleagues joining in on that, so we get it right. There's lots of examples of good practice, across the country, so we can draw on those and really get this quite pithy to be reflecting where we are against strategic objectives.
You and I are going to get on so well.
You've used the P word.
Pithy. Yeah.
Okay. Yes. The soft metrics and all those things that we have to measure ourselves against. So that's me. Happy to take any questions.
Martin first.
We can't ask them.
See, Sanj isn't here, so we've been through this report, and a bit more detail at the Finance and Performance Committee. And one of the things we asked for a couple of months back, which the team have tried to now provide, was some more up-to-date information, as you say, because one of the things I'm slightly nervous about is that, we are looking at March, albeit we had some sort of flash data on urgent care. And when you look at elective, whilst there's some good green shoots coming through on cancer, I'm still slightly nervous around, how we're doing against our laid down trajectory on the broader elective care, orthopaedics and the rest of it. And are we soon enough taking any sort of remedial action if we need to? Already nearly at the end of Q1, so I'm thinking if something is going off target and we're not cited on it, or certainly in the committee we're not, are we taking the remedial action, stroke mitigation soon enough, whether that's, buying capacity in the private sector or whatever it might be. We may be on trajectory, I don't know because I haven't seen it, but I'm still slightly nervous that we might be getting off trajectory and we just don't see it. I don't know if you've got any thoughts on that, certainly around the timeliness of information or whether those trajectories are there and being monitored somewhere.
I'm sure the trajectories will be there. I think the timeliness is really important and we need to focus on that. I don't know how up to date we can get the information. There's always that time lag, month end and things like that. So we just need to work that through.
So, let Kate try and help here.
So, most boards would get a bit grumpy if their data was 4 weeks out of date coming through the integrated performance reports to boards, or maybe 6 weeks out of date. But this is 3 months out of date. So contract reporting at the end of a month, remember the good old days of SUS and SLAM, we would be knowing what we think we ought to have and then knowing what's actually come through. So I think we should take offline why we've got a 3-month reporting lag coming into the ICB, because it means we can't have any assurance because we haven't got the data.
Thank you. Steve?
I did completely support that, but to note there is some detail, I think, on slide 12 on the soft metrics, which explicitly provides more up-to-date information in respect of 78 weeks and 65 weeks. Notwithstanding what Kate's just said, I support that. Martin, I think your challenge on elective performance is absolutely right, that there is a significant risk that we face as a system. And that's reflected in that particular slide that shows the number of over 78-week patients that our system currently has. It is improving, but not improving quickly enough. If we look at the position at the end of March, start of April, 329 patients waiting more than 78 weeks. That's improved, but only improved to 284 at the end of May. The vast majority of that is orthopaedics, and that is our risk going forward. And that's something that Rockhorn Hospitals Trust at the ICB are working very, very closely on in respect of opportunities to increase capacity internally, opportunities to increase capacity through private sector collaboration within the region, and opportunities through choice of providing access to that elsewhere. And I think John and Susan and it'd be helpful to have a more detailed summary of that, I think, at the next board meeting, given the level of risk that we're managing.
Okay. Martin?
We can pick up again as we develop the report, as you say, Steve, it's sometimes quite difficult on the committee and at the board to draw the line between, if you like, gaining some high-level assurance, versus delving into the detail of, can we see the orthopaedic trajectory and all the rest of it. We don't want to be right down there, but we need to somewhat be assured.
I'll get to that in a second. Ali, go first, then I'll make some comments.
Yeah, my point is in relation to the health assessments children looked after, and performance looks completely out of kilter and away from target. And I'm not assured by the slide of what the actions are to recover that position.
So I think, Ali, one of the things that we're clear on is that this doesn't tell the story of what happens next, which is why Kate's just saying this is a performance report and integrated. So, if you read through it, some of the discussion we had earlier around mortality, access, inequality, it tells the story through the metrics in here, but how we pull it together so that our population can see that we've got our hands on all the moving parts, and the same around some of the access to assessments and what we're going to do about it. I think that's the point Kate was making earlier.
Very good. So Kate, just a few observations from myself, if I may. There's something about, as we get towards the back end of this month, it'll be a year since we've started. And I think we've come on 1,000 miles from where we started. But we are going to have to do, each committee, and for that matter, board, a review of how we've done in the years, kind of thing. And depending on which committee chair I speak to, I get a different perspective on whether, in fact, the information being used is fit for scrutiny and assurance as opposed to update and detail. So you heard me chat earlier on, and Kate and I are on the same page on this, in terms of we need the detail, all right? But there's something then about bringing into the executive summary or into the top line things, whether it be FMP or whatever else it is this with the headlines. We've got 3 hours today to chat about something, make a difference, scrutinise. What are those elements? And the danger is you drop straight down into the detail. So there's something about what I'm going to call the BBC headlines. If you look on the BBC kind of thing, it tells you about elective or A&E or RTT or ambulance queue, etc., in a way in which most people can understand. I think we've got to get our performance reports that are in public as well in such a fashion that is easily understood at a simple level. That's that point. Taking Martin's observation, I think also it's helpful. If you look at the reports now, they're very good at looking at what we've achieved. We've got to get slightly better at looking at the actions we're going to put in place for the trajectories. And I think that's one of Martin's points in FMP. We would like to spend more time looking at the executive's plan, trajectories, and how do we support them and scrutinise that to make sure that we can do that. Taking, for example, Steve's challenge earlier on intermediate care, is this going to help going forward? Well, that's the opportunity for committees to do that. And to be fair, in the hope that we might move to joint committees going forward, all that information will be in there and we can all be cited on it and all then conclude on what actions are going to be taken together to actually do that. Okay? So if I could ask you to speak to the committee chairs as well, to see what they're after, that would be great. But apart from that, I think this is a huge leap forward, to be fair, from where we're at. But when would you expect to come back with not the draft, but your September. Oh, I'm excited for September to arrive.
I don't wish the summer away, John.
Anything else you would like to say on that? If not, I think really the recommendations here were principally to acknowledge and discuss the performance what we've done, be assured of the exception report, promoting development, etc. So I think we'll take all those recommendations as happy, but if you could just build on the comments you've got from colleagues.
Thank you.
That'd be really helpful. And one version of the truth, here we come, based on this, yeah? Very good, thank you. So, forward plan. Only thing I know I've mentioned it, but I want to formally minute it, if I may. We've got now 2 formal extraordinary board meetings coming up. The 21st, which is being done remotely, I understand. Yeah, remotely. And that is for the annual accounts, Simon, so you'll be ready and rocking to roll for the 21st.
Yeah, we're on track.
Yeah. And then on the 28th, we have the final sign-off of the joint forward plan, our 5-year plan, and the intermediate care strategy. Is there anything else, Carolyn, that you think we've missed for the agenda item on the 28th? If not, for those of you who are intending on coming to the away day on the 28th, at some point during the 28th away day in Saltash, we will be having the extraordinary board meeting. So, Carolyn, if I could just look to you to get a timing agreed, just so we've quorate, etc., to be able to go through that, that'd be great. Okay, 4 o'clock then. For those who
Well, I won't be able to be there.
No,
I need to
that's
leave earlier
fine.
than that.
As long as I just want to make sure we're core. No point having these things if we can't core it to be able to do it. So if you could just help us make sure there is enough people for quoracy, I'd be very grateful.
Can I just pick something up on
Yeah,
the
yeah.
annual report? So,
Yeah.
could we bring back to our next board meeting the plan for our annual general meeting? Because remember we talked about perhaps doing another True North event, and instead of doing our annual general meeting attached to a board meeting where we just accept the annual report, there is something about the people we brought together for True North being part of the critique of what have we done in our first year, and then how do we reorganise ourselves for our next year. And Andy, maybe this time Place should be leading the flow of the True North, and that will take a bit of time for us to get it organised, make sure people can come and all of that.
Very good. So looking to the forward plan, before I get into draw your attention to the detail of it, I will ask Molly to advise us and other colleagues under you, Carolyn, to consider how best we go about doing an annual review of our own committee's performance, and for that matter, the board as well. so that we can see whether we're fit for purpose and what we're doing is what we said we would do. So if you could organise that and come back and tell us how we're going to do that. It doesn't have to be on the forward plan. I just need to make sure that we have each committee chair prepped and ready to do a review of their own committees, please. Now, is there anything on the July or other months forward plan that we feel we should have or shouldn't have on here? Caroline?
So can I just say, Chair, that the engagement event of the gender equality and equalities piece, that will not be on there because it's actually part of another agenda item that's already on the board. So
Okay, thank
we'll
you.
be removing that. And then the only other thing I was going to suggest is that there's an item there that says greater detail on trajectories of years 3 to 5 of the joint forward plan. Bearing in mind the conversation that we've just had around revisiting the IPR and everything else that we're doing, can I suggest that we maybe bring that through into either September or October?
Align it with September based on Kate's observation earlier on. Should we do that? That's good call. That's a good call.
And my final point was there was actually, as you rightly say, green climate resilience item on there, which I now don't see. So we will need to
Correct.
put that back
on. I thought it was meant to be there and I couldn't see it. Wait a minute. Debbie.
So, Chair, I think we've agreed that we would do a biannual mental health partner deep dive, and that the first one would be in July, and I am lined up to present with Melanie Walker.
I think that's part 2, but if you want to bring it into part 1.
Is it part 2? Apologies.
It's
I'm
your
looking
choice.
at it. I don't think there's anything in the provider collaboratives that we wouldn't want to present in public. In fact, part of what we wanted to do was demystify
Very good.
the language around provider collaboratives and really talk about the benefits
Delighted.
to people
Delighted.
who use services.
So, Caroline, yes, Caroline?
Sorry,
is it on that point?
Yeah, it's on that point. So we'll have a bit of a clash then, obviously, if that's coming into part 1, because we've got the bi-monthly community update in there. So for North and East, which is obviously Andy.
I was just going to jump in there, Sharon. I don't know if this is offline. I believe it's West ICA's turn. I think North and East did 4 months ago, Central did 2 months ago, and it's West's turn personally. But if I'm wrong in my scheduling and
that's
I'm
fine. We
required to
can
lead, then I will do so. But
just make sure we balance the two, that's all. Yeah.
Capture the point. But we're agreeing that, Debbie, you're going to be in part 1. So we'll drag that forward. And
If the agenda allows for
So
it.
yeah, we'll make it happen.
Yeah,
we'll
we,
make it
we
happen.
could increase the length of the
Yep,
meeting, couldn't
we'll-
we, and
we'll make it
reduce
happen.
part 2.
And Andy, can I just be really clear that you and Chris are clear? And if you're not, let's chat offline about the deep dive for September on primary care. If you're not now, let's not take up time now, but let's make sure
we'll take it offline. My understanding was that deep dive we were going to lead on dentistry, and we're going to have a general medical practice one in part 2 next board. But I think we'll take that offline, Chair, and just be clear.
So Karen, if you could take that away, because I think I'm picking up not quite clear. And can I take your point about the AGM?
Yeah.
How are we going to deal with that?
So we'll take that away and we'll work. What I don't want us to do is to do an AGM attached to a board meeting when we get 3 members of the public come in.
Yeah.
When we launched the ICB with a dedicated event that had people in the room telling us what they thought.
Yeah.
So I think we need to account back to the people that told us what they thought and ask them to tell us again. They might say we've not done very much.
No.
That could be a
Very
massive
good.
risk. They might say we've done loads. I don't know.
Very good.
Perhaps we could engage the people who've been part of the vignettes in that.
Oh, it's a brilliant idea. Brilliant idea.
Thank you. Ali?
Yeah, thanks, Chair. I've been asked to request that civic universities agreements on the July agenda.
So we will. The civic university agreement has to go through our executive processes, Ali. So it's not been seen by the ICB exec or SEG. So it needs to go through that. And I think probably would it be QPOC that would see it? And if we can't manage to do that, I don't think there's any reason why we couldn't ask for an offline view from our non-executive members before it comes to the board. But we'll do that for July.
Yeah, we'll do it for July, Ali.
brilliant,
It's just got to go
thank
through due process and we're away. Okay, happy with on forward plan, everyone?
Brilliant, thanks.
Yeah, I'm getting lots of nods on there. Are there any questions from members of the public relating to the agenda? I'll wait for a second. In case the hands... No? Very good.
So I have offered John that because the questions that John and Nigel asked were very data driven, that we do a written response that we send to them as part of the minutes for this meeting. And Nigel Mawson's offered to meet with us so that the written response is sufficient for him to be able to use it to provide confidence to people that they can use 111. So Susan, he's offered to meet with you as part of getting the written response out.
Okay.
Okay, so just before I close the meeting then, can we agree what time we're going to start after lunch? Now, we're running about 25 minutes late. I think, Caroline, we were going to start at 1:15. Is that 1:45?
I need you to come back at 1:15.
Yeah. Sorry. We were going to start at, yeah. I'm going to say, as it's now nearly 1:15, we actually come back with half an hour from now, which is 20 to 2, and we try and catch up. Does that work for everyone? Lovely. So we'll close the public meeting now. Thank you very much, everyone. See you at 22. Thank you. Well done, you.